the last the last class we stopped at PCP. So today we'll continue with anthrax, and this is something we're already familiar with. So anthrax it's a disease that is caused by the Bacillus anthracis organism, and it is a gram-positive spore-forming organism. So majority of the problem from this anthrax comes from inhalation of the spore, and it's very common in farmers, veterinarians, people that get exposed to the animals, you know, animal product like the wool, the hair, the hide, even the milk or the meat, because all these things can harbor the spore of this bacillus. And it's very important for us to remember that we have three major forms: the cutaneous, the inhalational one or the pulmonary, and the gastrointestinal form. The most common form is the cutaneous form, then followed by the pulmonary, then the gastrointestinal one. We should not forget that it is not transmitted from person to person, so it doesn't spread by personal contact. It can only be gotten either from cutaneous inoculation, from inhalation, which is the pulmonary one, or from injection. So anybody that takes in the bone meal can get the GI one. Anybody that inhales the spore from the animal wool or the hair can get the pulmonary one. Anybody that has any form of traumatic inoculation of the spore into the skin can get the cutaneous one. So the cutaneous one usually follows the traumatic inoculation or penetration of the spore into the skin, and it classically have these ulcers. It usually starts as a painless purple, and with time it progresses to form vesicles. The vesicles will ulcerate, and they will have this central necrotic center with surrounding edematous border. So this is called the eschar, the eschar. We should not forget the component of the toxin of this anthrax, because once the spore are being inhaled, or they are being ingested, or they are being inoculated into the skin, they are going to germinate and they are going to release the toxin. And the toxin contains two major components: the leader factor as well as the edema factor. So the edema factor is the one that works like the other ones, like the E. coli that cause the diarrhea, the pertussis. All of them work together to increase CMP, which causes water absorption, explaining the edema you see at the border. So why the leader factor inactivate the mitogen activated protein kinase, leading to cell death and the eventual necrosis, you see. So both of them work together, explaining the pathophysiologic presentation of what we see. So we should not forget, once we are seeing necrotic tissue surrounded by edematous border, we already know they are trying to describe the black eschar, which is associated with anthraxis, the cutaneous form. Why the inhalational one? The only thing I just want us to pay attention to there is the fact that it causes severe mediastinitis. So once an individual inhales it, it goes straight like to the airways, mediastinum, and they can have fever, they can have chest pain. Chest pain is very cardinal. Forget about the fact that it's omitted. It's very important. It gives an important presentation in mediastinitis. Fever, chest pain, difficulty in breathing. And because of the fact that that toxin tends to damage the blood vessels within the mediastinum, they are going to have bleeding in that mediastinum. So it can progress to form hemorrhagic mediastinitis. And that is going to present as widening mediastinum by the time you do your chest x-ray. And don't forget, the chest x-ray is not going to have pulmonary infiltrate, because this is not classic pneumonia. So you are going to notice that the patient is going to present with fever, with chest pain, with features of bleeding like hypotension, hypoxemia. By the time you do your imaging, you are going to see widening mediastinum And on your imaging, you will not see any pulmonary infiltrate. That is classic for the pulmonary presentation of anthrax. So in some cases too, it can be complicated by pleural effusion. So don't forget, hemorrhagic mediastinitis is the hallmark due to the vascular destruction from the toxin. Then people with the GI one, people that have ingested meat or animal product that is containing the spore, they can have, nausea, vomiting, bloody diarrhea, abdominal pain, just normal GI presentation, but with bloody diarrhea. So how do you make your diagnosis for anthrax? You want to do a culture isolation. You want to take a swab from the skin. You want to take respiratory secretion, you know, or you want to obtain rectal swab or oral swabs, for the GI one, and you want to culture. And we remember from our step one, what we are going to see. We are just going to see colonies of coma-shaped projection that looks like the Medusa head. So once you see that coma-shaped projection that looks like the Medusa head, we know they are talking about anthrax. That's what they are talking about. So that's for the culture. If you are not doing the culture, you can use two non-culture tests, which is in between the three, including PCR, immunohistochemistry, or ELISA. So PCR is very straightforward. You are just analyzing the gene sequence. So once you do your gene analysis, you do your gene amplification, and it's in keeping with what you have for anthrax, you keep it. You can combine that with immunohistochemistry, in which you are trying to check for antibody to some certain protein. What protein are we looking at now? I must also tell us or remind us that this Bacillus anthracis organism is encapsulated, and it is the only organism that has the capsule, the peptide capsule made up of poly D glutamate. So most of the other capsules are made up of carbohydrate, polysaccharide, but this one has a polypeptide capsule which is made up of poly D glutamate. So you can check for antibody against that peptide, and you can stain the product. So once you get your particular specimen, you uh that contains the antigen, the antibodies too is going to be sorry, you are going to introduce the antibody to the uh that can bind to that particular peptide, and you stain it, you identify it on your immunohistochemistry, or you do your ELISA, in which you are going to assay for the antibody against the toxin, through your ELISA diffusion panel. So any one of the three, just use two and you make your diagnosis. And on chest X-ray, you are going to see the widening mediastinum we have talked about, or associated pleural effusion. So it's very, very sensitive in people that has the inhalational disease, because they are going to have hemorrhagic mediastinitis, and you can make your diagnosis too from there. So the treatment is just remembering DC, doxycycline, ciprofloxacin, doxycycline, ciprofloxacin. You can use any one of them, any one of doxycycline, ciprofloxacin. In some situations, you can add some additional antibiotics. For example, someone that has, because sometimes it can progress to cause meningitis. So, but I don't feel that one is very important for us. Most of the questions that they ask around anthrax, it doesn't go beyond doxycycline or ciprofloxacin. So people that have the inhalational disease, which is severe, or the cutaneous one, which is confined to the face, the head, and the neck, you want to give them cipro or doxy for at least 14 days. While those ones that have the cutaneous one, you can give them any one of that for 7 to 10 days. And if you get the history that somebody is exposed, to animals that, have that fungal, that bacterial spore, you might want to give them PEP, against that infection. And that is just ciprofloxacin only for 60 days. So everything revolves around DC. Doxy or Cipro for the treatment, Cipro for the prophylaxis. So moving on to acute pharyngitis. Acute pharyngitis is just like infection of the pharynx. That is it. Most of the time you get it from viral infection, but sometimes you can have superimposed bacterial infection on the virus, on the viral infection, or sometimes even started from bacterial infection. So most commonly group A, which is a gas, Many people don't know that Neisseria gonorrhea can cause pharyngitis. It can cause pharyngitis. And of course, we are aware that Corynebacterium diphtheria can cause pharyngitis. But 90% of the situation, it is from viral infection. The rhino, the corona, the herpes, just think about the herpes, Epstein-Barr, cytomegalovirus, herpes simplex, influenza, all of them can cause pharyngitis. But the one we are going to be interested in is the one I share with the group A streptococcus. So early antibiotic treatment for streptococcal pharyngitis can prevent rheumatic fever, not glomerulonephritis. So this is from studies. I'm not the one that said it. So we have to pay attention to that. Antibiotic treatment can protect against rheumatic fever, but it will not protect against streptococcus glomerulonephritis. So somebody having acute pharyngitis from gas from group A streptococcus, if you give the person antibiotics, you are actually protecting the person against rheumatic fever, but the person might not be protected from glomerulonephritis. So, so what are the features that are typical for the group A streptococcal pharyngitis? Uh, of course, history of fever, because it's an infection, so you expect fever, sore throat, tonsillar exudate, very, very important. Fever greater than 38, tonsillar exudate. You see some whitish spots within the tonsils. They are going to have tender cervical lymphadenopathy, very, very important feature. And of course, they can also have the scaleniform rash. So the sandpaper-like rash, another features of scarlet fever, because we know that scarlet fever is caused by the gas. So somebody can have scarlet fever and streptococcal pharyngitis will also be part of the accompanying presentation. So an individual can have fever, can have tender cervical lymphadenopathy, can have tonsillar exudate, can have body rash, which has this sandpaper feeling. You tell the person to bring out the tongue, you are saying the strawberry lesions. That is in keeping with streptococcal infection, particularly from the group A. So we are going to talk about the central criteria where we are going to narrow down the important symptoms that we need to remember. Then, for the atypical features of the streptococcal pharyngitis, that is the symptoms that you are going to see, and you should not have a high index sufficient for. Oh, sorry, please, 1 minute. I think I'm opening the wrong because I know I added some little notes to that place. Uh, let's hope I'm not opening the wrong document. Should be some little notes there. So sorry. Okay, yeah. So this is the right one. So um, so once you get all these features, you know that it's not in keeping with the group A streptococcal pharyngitis. What are these symptoms? Coryza. So somebody having runny nose, coryza like what you have in viral infection like measles. Hoarseness of voice, is not in keeping. Rhinorrhea, you know, uh, cough. They don't have cough. So it's one of the symptoms that is absent in group A pharyngitis. They don't have cough. Conjunctivitis, you can see that in something like measles, some of those herpes, anterior stomatitis, herpes, ulcerative lesions, herpes, GI symptoms, measles, corona. So all these ones are more in keeping with the viral infection. You don't see it in people with group A bacterial streptococcal pharyngitis. So how do you make diagnosis of group A streptococcal pharyngitis? You can do that by your clinical evaluation, which is the most important. If you are not still getting enough evidence from your clinical evaluation and you still want to proceed, you can do your rapid group A streptococcal antigen detection test, which is a very fast one. If you still have high index of suspicion, you can now confirm with your throat culture if your gas antigen detection test is negative. So let us look at the central criteria, which is the clinical parameters that we use to make diagnosis of the group A pharyngitis. the first thing to have at the back of our mind is this infection is common in people within this age group, 3 to 14 years. 3 to 14 years. So anybody within this age group takes 1 point immediately. So then the acronym is NOT, NHO, NHO, no cough, NHO, no cough, then the T's. So temperature greater than 38, that's a fever, tonsillar exudate, and tendal anterior cervical lymphadenopathy. So NOT, no cough, there's fever, which is the next T, fever of 38, tonsillar exudate, and the tendal anterior cervical adenopathy, lack of cough, and the age group, which is 3 to 14 years. So this is the entire 5 points that you need to remember. Then anybody between the age of 15 to 45, they take 0. Anybody beyond 45 years, you give them -1. So that's the algorithm you are working with. How do you interpret this? If anybody scores between 4 to 5 points, you treat them empirically with antibiotics. Give them penicillin because you have a very high evidence that what the person is dealing with is the group A streptococcal infection. But if the person scores 2 to 3 points, you have to proceed to confirm by doing your rapid gas antigen test. So if it's positive, you are going to give the antibiotics. If it's negative, you can do your throat culture. So if your throat culture is positive, you can treat. If it's negative, you just treat symptomatically. You don't give any antibiotics because it's likely to be viral. But if somebody has 0 to 1, you don't need to do any testing. You don't need to do your rapid antigen test. You don't need to do any throat culture. There's no antibiotic that is indicated because it's likely to be viral, or you are sure that it's outside, your gas. So you just do your symptomatic treatment. You can give the person, saline wash just to reduce inflammation. You can give antipyretics. You can hydrate and all those things. So how do you treat someone that has gas? Somebody that has 4 to 5 points, you want to start your empiric antibiotic treatment with penicillin for like 10 days. But in some individuals, they might have penicillin allergy. So you can consider some alternatives like cephalosporin or azithromycin. So these are the combination of drugs that can work: penicillin, cephalosporin, amoxicillin, or azithromycin. All of them work against the group A streptococcal infection. So don't forget, once you make your diagnosis 4 to 5, you can give penicillin for 10 days. You can give azithromycin. You can give cephalosporin. You can give amoxicillin. If your score is between 2 to 3, so you might need to investigate further by doing your gas rapid antigen detection test. If it's positive, you start your medication. If it's negative, you proceed to do your throat culture. But if you get a value between 0 to 1, you know that it's very, very unlikely. So you don't place on antibiotics. You don't do any further test. You just treat symptomatically. So for the symptomatic relief,
Please, can you take that again, please?
so it's
Yes,
just
please,
me
if
just
possible, from the center, I beg. Please,
if it's positive from where?
from the center criteria, the modified center.
Yeah, so this is the knot. Talking about the knot, the no part of the knot is talking about no cough. The remaining is talking about the 3 T's. So the age group, 3 to 14 years. 3 to 14 years scores 1 point. The no there means lack of cough, no cough, 1 point. Because it's in keeping with people with the gas, they don't have cough. The viral one, we have cough. Then the 3 T's. The first T, temperature greater than 38, 1 point. That's a fever. The next T is a tonsillar exudate. The third T is a tendal cervical adenopathy. So that's 5. If the person is within the age of 15 to 45, 0. If the person is more than 45 years, you further -1 from the point that the person has scored initially. So you now look at what you have. How many points did you have? If you get 4 to 5 points, that is high risk for gas. You start your empiric treatment immediately with your penicillin. your amoxicillin, your cephalosporin, or your azithromycin, any one of them. But the best or the most preferred choice is penicillin for 10 days. The person scores 2 to 3 points. So you are not sure if the person has it or not. The person is just in between. So how do you delineate? You do your rapid antigen test, right? If the rapid antigen test, after you have collected your throat, swab, you subject it to rapid antigen testing. So if the rapid antigen test is positive, you can treat it as if the person got 4 to 5 points by starting your antibiotic. But if it's negative, you still need to proceed and you do your throat culture. So if the culture is negative, you treat symptomatically. If the throat culture is positive, you give your antibiotics. So if the person scored 0 to 1, this is low chance of gas. You don't bother doing any culture, you don't bother doing any antigen test. You just treat symptomatically as if it's viral. So do you understand that?
Yes. So, but if if the throat culture is negative, okay?
Yeah, you treat as viral. You treat
As viral.
symptomatically.
Okay.
So you give for your symptomatic treatment, you are just hydrating, tell the person to rest, give antibiotics for the fever or whatever stuff the person might be experiencing, and you give salt water gargle to limit the inflammation and the pain within the throat that the person might be experiencing. So what are the complications of acute pharyngitis? So it's been divided into two forms, suppurative and the non-suppurative. Suppurative just means the one that the individual can form pus. The non-suppurative ones, there's no pus formation there. So the non-suppurative ones are the one that are shared with the immune, the kind of hypersensitivity kind of reaction, antibody involving. So type 2 hypersensitivity leading to acute rheumatic fever, or type 3 hypersensitivity leading to the post-streptococcal glomerulonephritis. So we know what acute rheumatic fever presents with. We know post-streptococcal glomerulonephritis. The suppurative one, they can form pus because it involves the neutrophils, the macrophage, all of them coming together. So it can be as small as cervical lymphadenitis only. So they can just have cervical lymphadenitis that can just, progress to form an abscess, and there's going to be suppuration. So, or it can even be the bad that it can affect the hair. We know that the pharynx is very close to the hair, the nose, ENT, they are together. The throat, which is the pharynx, the nose, which is the N, and the hair, which is the he. So you can have ascension from the pharynx to the nose because there's a tube that connects the hair to the pharynx, the nasopharyngeal tube or the Eustachian tube. So you can easily have transfer of the infection to the middle hair, causing otitis media. And we know that the mastoid bone, the mastoid part of the temporal bone, forms the major cavity of the middle hair. So you can easily have the spread of the infection to the mastoid bone, leading to mastoiditis. So you just know that the person is going to be complaining of pain, redness within the back of the hair. So it can also move further above, to the sinuses. Causing symptoms of sinusitis, the person start having rhinorrhea, nasal congestion, fever, headache, depending on the part of the sinus that is affected. And it can get worse that it can spread to the space beyond or at the back of the posterior pharyngeal wall. So it can even move backwards around the pharynx, causing retropharyngeal abscess. I think Dr. Babandi is going to talk about this when we get to the pediatric section. So that individual is going to be having fever, neck pain, and rigidity. The pharynx is just picture the pharynx as part of the neck. So you have an abscess there that is collecting. That individual is going to be having severe neck pain and rigidity. it will be bad. It can be bad that the person might even find it very difficult to open the mouth, and it can even compress on the airway, leading to stridor, difficulty in swallowing. Because they cannot they cannot swallow, they will start drooling saliva. So they can have drooling, they can have stridor, they can have dysphagia, severe neck pain, neck rigidity, and fever. So that should raise our suspicion for retropharyngeal abscess, particularly if this person had history of acute pharyngitis before. Then another one is a peritonsillar abscess. Peritonsillar abscess is very, very easy to remember. And also, for the retropharyngeal abscess, you might need to do some investigation like your chest X-ray. You look at the prevertebral diameter. It's going to be very thick. It's going to be more than the diameter of the C2 vertebrae. So there's this value that the radiology used to talk about, but I don't think that's very important for us. But we just know that the prevertebral diameter is going to be very enlarged. Then, then the peritonsillar abscess is another complication. It can spread around the tonsils, and it presents similarly like the retropharyngeal abscess. They are going to have neck pain, they have fever, they have trismus, they cannot open the mouth, they cannot swallow, they are drooling, just like that. But by the time you open that mouth, you are going to notice that the person is going to be having unilateral tonsillar enlargement. That's the first thing you are going to see. And what is going to give it out quickly is that you notice that the uvula is going to be deviated. So if the abscess is occurring within the right side of the tonsil, it's going to be pushing the uvula to the left. So once you see uvular deviation, unilateral tonsillar enlargement with all those other stuff that we have talked about, difficulty swallowing, painful swallowing, difficulty opening the mouth, neck pain, fever, drooling, muffled hot potato voice. They are finding it very difficult to pronounce the vowels. But most importantly, unilateral tonsillar enlargement and uvular deviation. You know that is peritonsillar abscess. Straight up, that's peritonsillar abscess. So it can be a complication of acute pharyngitis. So what you want to do, you can definitely obtain some part of the fluid and culture and drain with antibiotic cover. So you can localize the abscess by doing your intraoral ultrasound or CT scan, and when you get it, you can aspirate part for culture, and also you are going to even take everything out and place on intravenous antibiotic cover. So that's that about the peritonsillar abscess. Don't forget about the unilateral tonsillar enlargement. Don't forget about the uvular deviation. People with retropharyngeal abscess can develop acute necrotizing mediastinitis. So I think when we start talking about the retropharyngeal abscess, we are going to see the layers of the neck, the way they are divided. So when we get to the retropharyngeal space and we descend downwards, we are moving downward into the mediastinum. So we can have spread of the infection from the retropharyngeal space downward into the mediastinum. And when it gets to the posterior mediastinum, it can spread around the mediastinal content, particularly the lungs and the heart. So it can cause pericardial effusion as well as pleural effusion, even mediastinitis too. So that's one of the life-threatening complications of untreated retropharyngeal abscess. You don't want it to spread to the mediastinum because you are scared of the person developing mediastinitis, pericardial and pleural effusion. So,
Sorry, Dr. Babalo, is there a time it can be confusing to say whether it's retropharyngeal abscess or peritonsillar?
no, it won't be
From a
confusing.
question.
It won't be confusing. You already know what to look out for. So, once you want to delineate it, look out for your tonsillar enlargement. Are you seeing any stuff about unilateral tonsillar enlargement or uvular deviation? If they are not putting any stuff like that there, go for retropharyngeal abscess. You'll not be wrong. But most of the time, if they want to tilt your mind towards peritonsillar abscess, you are going to see the uvular deviation and the unilateral tonsillar enlargement. It gives it out quickly. So then I almost missed something, which is thrombophlebitis of the jugular vein. So it occurs when the pharyngitis the inflammation starts spreading around the tissue around the pharynx. They migrate into the peritonsillar vessels. Then from the peritonsillar vessels, they can get into the internal jugular vein. So when the infection get into the internal jugular vein, and this infection that is actually spreading is the Fusobacterium, not the gas. Because what happens is that once the acute pharyngitis occur and there's inflammation around the pharynx, it's going to lead to colonization of that pharyngeal area by the anaerobes of the mouth, particularly Fusobacterium. They are there, but they don't cause any infection. It's just like actinomyces causing all those abscesses in the face. Actinomyces is fine, it's part of the anaerobes in the mouth, but it doesn't cause any problem unless there is a fatal, ground for it to proliferate. When there's devitalized tissue or there's trauma or something in the face, that's when you see it being activated. The same thing happens here. So once the pharyngitis sets in and you have inflammatory spread around the pharynx, you are going to get colonization of the Fusobacterium, which migrates into the peritonsillar vessels. From there, connect to the internal jugular vein. And when it gets to the internal jugular vein, it's going to provoke an inflammatory response within those veins that is going to lead to thrombophlebitis of the vein, because there's going to be actually a formation of clots. Now the problem now lies when the clot starts migrating. So, because from the IJV, it can move downwards through the brachiocephalix, SVC, right side of the heart to the pulmonary vasculature. So, this individual can suffer a PE from thrombophlebitis of jugular vein. It can move beyond the PE and go to the left side of the heart, and get shower to the systemic circulation. So it can go to the joint, causing septic arthritis. It can go to the remaining part of the body, leading to septic shock. So that's why it is very, very dangerous. And you might not even catch it on time because of it's where it's coming from. So you have to have a very high index of suspicion for this condition. And the implicating organism is the Fusobacterium. Please don't pick group A strep, but the Fusobacterium. So we call that the Lemire syndrome. So
It's a quick one. In case they want to describe it potato voice, is it just that they will talk about the vowel thing you mentioned? Is there another way they could describe it?
yeah, they can say the person cannot. Well, I've not seen any typical stuff, but they can express it like that. Maybe you tell the person to pronounce A, having difficulty pronouncing A, E, I, O, U, something like that. But sometimes they can even put it like this, that the person is having this kind of voice. So as if the person is having a hot, bolus in his or her mouth. They can put it that way. So it's just additional, clinical feature. It's not that we should, be looking out for that. That it's not something that can be easily expressed. But the ones that are very, very important, that are high yield, are those two that I've mentioned: tonsillar enlargement and uvular deviation. You will be fine definitely once you remember those two. So all patients with history of rheumatic fever should be given routine penicillin prophylaxis, because you want to prevent recurrent infection. And don't forget, this what's it called, the penicillin prophylaxis will also prevent them from developing the rheumatic fever too, particularly people with past history of acute pharyngitis. So moving on to the oral infection, Ludwig angina. So Ludwig angina is just a condition where you have inflammation or infection of the submandibular space. The submandibular space. It usually follows dental infection. So somebody that has dental infection, particularly within the root of the second and the third molar. So because The root of the second and third molar extend downwards beyond the mylohyoid muscle. They can easily spread into the submandibular space that is just beneath them. So, infection of the submandibular space is Ludwig angina. It can also affect the other arterial spaces, that is submental space, like the sublingual space, but the major one is the submandibular space. And for the implicating organisms, you have to think about the gram-positive, particularly the viridans, Staph aureus, and the anaerobes. The viridans, Staph aureus, and the anaerobes. Don't forget the commonest cause of Ludwig angina, which is infection of the submandibular space within the floor of the mouth, is when you have dental infection, particularly involving the second and the third molar. An individual can get this when they have mandibular fracture. I think I have them here. Mandibular fracture, somebody that has penetrating trauma or cut to the mouth. So they can tell us that a child, suffered trauma or injury to the mouth after falling on an object or something, or an individual with cancer of the mouth, oral cancer, oral ulcers from any type. They can easily spread to the submandibular space. And what are those things you are looking out for? That individual is going to be having painful neck swelling. So just look at the part of the neck, the part that is just distal to the chin, where the beards are, that area is going to be very swollen. It's going to be reddish. If you tell the person to open the mouth, if the person can open the mouth, you notice that the floor of the mouth is raised because of the inflammatory response. You notice that the tongue, falls backwards. The tongue falls backward. The person cannot even swallow. The person will be drooling. The person will be very, very, uncomfortable and find it very difficult to speak. And because of the tongue falling backwards from elevation of the floor of the mouth, the person can easily have, airway compromise and difficulty in breathing. So you also have to watch out for impending signs of respiratory, difficulty or arrest, like the person already having cyanosis, person having stridor or lockjaw. So when it gets to this stage, you want to act quickly. So you can make diagnosis by doing a CT scan. It will give you a very clear view of what is happening within that submandibular space, and you have to be very active with the airway management. So ABCD. So you want to be sure that the airway is not compromised, or it is not at the verge of getting compromised. So if there's a need, to assist with the breathing, you sit the patient upright and you give, the max nasal prompt to deliver oxygen. Even if you want to intubate this kind of patient, this is not a patient you are going to be doing endotracheal intubation, because you need to pass the tube through the mouth, but that mouth is already blocked. So you have to take it through the nose, and nasotracheal intubation requires a lot of expertise. So you can attempt nasotracheal intubation, but if you can't do that, you can do cricothyroidectomy, because your cricothyroidectomy is just making a hole within your cricothyroid membrane, just distally within the neck, or you just do your tracheostomy tube. Any one of them. If that person has this feature of airway compromise, cyanosis, person's already, having stridor, trismus, you want to quickly take over that airway by doing these procedures. So what are you going to do to treat an individual with this? You have to give IV empiric antibiotics to cover for the viridans, the staph, and the anaerobes that we have talked about. So you want to give amoxiclav for your gram-positive, or cefuroxime, or meropenem. All these guys that we are giving are active against bacteria that have the beta-lactamase. So that is bacteria that can, cleave, this beta-lactam. So you want to give amoxiclav, cefuroxime, meropenem with clindamycin or metronidazole to cover for the anaerobic component. So you want to give that for 48 hours IV. So ideally, you are supposed to notice clinical improvement within that 48 hours. Very, very important. So if you notice clinical improvement, you can now switch to oral, drugs for about 2 weeks. But sometimes you might not get improvement within 48 hours. So that is an indication for you to go in, do your incision and drainage, particularly if your medical treatment fails within 48 hours. You should also do I&D in an individual that has airway compromise, or you did your imaging, your CT scan to look at the deep neck space, you are seeing evidence of abscess. You have to do I&D in that situation. So radiological evidence of abscess, people with airway compromise, or people that are having spreading infection down the neck or down the chest rather, you have to do your incision and drainage of that abscess that is collecting within that region, because that is the reason why that person is failing medical treatment. That's the reason why the person is not getting improved within 48 hours of starting your IV broad spectrum antibiotics. So don't forget, the diligent airway management is very, very necessary. Very, very necessary. Once you notice the person is undergoing this clinical deterioration, having stridor, trismus, having cyanosis, you quickly want to do your nasopharyngeal intubation, or you want to do your cricothyroidectomy or your tracheostomy to secure the airway. Then, if there's any evidence of abscess, you want to quickly do your I&D. Radiologic evidence, failure to improve within 48 hours of treatment, airway compromise. Your abscess is collecting, and that's the reason why the person is finding it very difficult to recover. So, for acute lymphadenitis,
So you said, first of all, the infection is in the submandibular place and can follow second and third molar infection or procedure.
Yes.
Okay.
Yes.
And can also be subject to mandibular fracture and other features.
Yes.
Then the organisms, I said polymicrobial, he said Strep viridans. I just want to be sure. He said Strep viridans, Staph aureus, and the anaerobes.
Yes, that's correct.
Oh, okay.
So for acute lymphadenitis, so this is just inflammation occurring within the lymph node, particularly the cervical lymph node, because we are talking about the respiratory system here. So the most common one that's affected the cervical lymph node, most of the time it is unilateral. So if it's bilateral, you want to think about something else. Maybe the viruses, influenza, Epstein-Barr. But most of the situation, if it's bacterial, it is unilateral. And the ones we are talking about here is the bacterial ones, the ones that are caused by Staph aureus and the Strep pyogenes. They are unilateral and they have a rapid onset. Within 1 week, they resolve. So it can affect the submandibular lymph nodes too, and antibiotics may be required when you are having impending signs of abscess formation. Antibiotics are indicated when you have impending signs of abscess formation. Actually, when you notice signs of fluctuance, it means that there's abscess. You need to drain. But if you notice that that area is getting reddish, you are seeing tenderness there, the fever, you know that okay, this person might progress to forming abscess very soon. You can quickly give your antibiotics to prevent abscess. But if there's fluctuance, there's abscess, you need to drain. Very, very important. So the common organisms there, Staph aureus, strep pyogenes. They resolve usually within 1 week and they are unilateral. That is it. You can have some chronic infections too, like someone having TB. They can also cause unilateral lymphadenitis, but it will be for more than 1 week. They are usually chronic. But if you are having lymphadenitis for less than 1 week, unilateral, you can consider your Staph aureus or your Strep pyogen. So moving on to sinusitis, this is actually inflammation of the paranasal sinuses. The most common sinus that is affected is the maxillary sinus. So the reason why this occurs is because the maxillary sinus drain against gravity. So we have the diagram that shows the sinuses here. We have the maxillary sinus here, which is here. So, and the way it drains is that it drains into the middle meatus. So we remember the PS, FAM, and the HIN. So I don't know. That's just the way I learned it. So FAM, 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 FAM drains into HEM, FAM. So F frontal, the A anterior ethmoidal, and the HEM maxillary all drain into the middle meatus. They drain into the nasal cavity. The meatus are formed within the nasal cavity. So it drains into somewhere here. So, and this drainage is superior-medial. This is where it is draining into. So it's placed, that drainage is placed superior-medial to the maxillary sinus. So that's a little bit difficult. You have to be draining against gravity. If it's draining into this area now, then it's very easy because it's going to be draining in direction of gravity, but it's upwards. That's hard. So there's a very high chance of mucus accumulating within that area, providing a site for the viruses, the bacteria to proliferate, leading to inflammation and, the sinusitis at the end of the day. So going back to, where we are, yeah. So two forms of sinusitis, the acute and the chronic form. So depending on the number of months, of which the symptoms is lasting, we can categorize into acute or chronic. So acute one usually lasts for less than 1 month. 1 month. Most of the time, they are caused by viruses. So you now have bacterial superimposing on these viruses. That's the way it is most of the time. Most of the time, the viruses are self-limiting. Within 5-7 days, they have disappeared. But sometimes you can have the inflammation being terrible, and there's going to be impairment of the ciliary activity within those sinuses, and they cannot bring out those mucus, and you have stasis and the bacterial superimpose, causing the inflammation, bringing about the acute bacterial sinusitis now. And the bacteria that we have to think about is just three. Strep pneumo, H. influenza, and Moraxella catarrhalis. So those are the three bacteria that we have in acute bacterial sinusitis. Don't forget, most of the time, sinusitis is from virus, rhinovirus. Most of the time, rhinovirus. But they can get superimposed with bacterial infection, and the three bacteria: strep pneumo, H. influenza, Moraxella catarrhalis. Commonly, it can affect the maxillary sinus because of the fact that it drains superior-medially against gravity. So there's high chance of, mucostasis within that area. So what are the stuff that you are going to see that is going to raise suspicion for bacterial sinusitis? That person is going to be having purulent nasal discharge. Purulent nasal discharge. That's bacterial. Neutrophils are involved now. They are dead. Purulent bacterial discharge. That person is going to be having facial or tooth tenderness. So this one is very, very common if it's affecting the maxillary sinus, because we know that the maxillary or the maxilla contribute part of the jaw, right? The bone of the face. So kind of it forms the upper part. So, and it houses the teeth. So that person can have, pain within the maxilla bone, causing tooth tenderness. They can have facial pain because it forms part of the facial bone, facial pain. It can spread upwards, to the frontal sinus, and they can have headache. They can go to the sphenoid sinus, and they can have retroorbital pain. So depending on the sinus that is affected, but because we are looking at the maxillary one, which is the commonest one, so they will just have the facial or the tooth tenderness. They can have prudent nasal discharge. Because of the congestion within the sinuses, they will have impairment in perceiving smell, so they can have hypoxemia or anosmia, and the symptom is definitely going to last for more than 10 days but less than 1 month. So normally the virus will have resolved within 5 to 7 days, but if you are seeing that the nasal congestion, the nasal discharge, the facial tooth tenderness is lasting for more than 10 days, you want to have a high suspicion for bacterial superimposition. While for chronic sinusitis, the symptoms usually last for more than 3 months. So they are going to be having the fever, they are going to be having the nasal discharge, the nasal congestion. It's going to be purulent, it's going to be foul smelling, and it's going to occur for more than 3 months. So, you are working with an individual that has chronic sinusitis, so you want to think about other associated disease, like is it that this person has allergic rhinitis, or the person has cystic fibrosis, or the person has asthma, or the person has nasal septal deviation. So an individual that has nasal septal deviation can have chronic sinusitis because this anatomic abnormality is going to impede nasal drainage. So they can have nasal accumulation leading to chronic sinusitis. People with some vasculitis, they can have chronic sinusitis like Wegener's. Wegener's affect both the upper respiratory tract and the lower respiratory tract. So they can have sinusitis with Wegener's. Don't forget the headache, the purulent discharge, nasal congestion, the anosmia, the hyposmia, the tenderness of the face, the tooth can persist for more than 3 months, and that is talking about chronic, disease. So, and these are the shared conditions that can cause chronic sinusitis. So, what are the complications of sinusitis? So, everything is just about spread. You can talk about spread to the other contiguous sinuses. We have talked about the surrounding sinuses, for example. Just within the maxillary sinus, we have the frontal sinus just above it. So it can spread upwards to that frontal sinus, and it can affect the bone there, causing frontal bone osteomyelitis. So it can also, form a subperiosteal abscess. You can just have that collection with beneath the periosteum of the bone. So it can move into the intracranial segment and lead to meningitis. It can cause brain abscess. It can cause cavernous sinus thrombosis, and we know how these people are going to present because we have done neurology. So those are the complications of sinusitis: intracranial and the other neighboring spread. Sometimes they can form mucoceles. So mucoceles are just benign epithelial cysts. Just that recurrent inflammation is going to be is going to cause formation of cysts within the epithelial lining of the sinuses, and they will appear as mucoceles. It can go to the eye, orbital cellulitis. It can even disseminate widespread and lead to sepsis. So, Ludwig angina, again, key fact is bilateral cellulitis of the submental, submaxillary, sublingual. They did not even mention the submandibular, which is the most important one. Space, from an infected tooth. Don't forget that. From an infected tooth can occur following fracture, can follow oral ulcers, oral malignancy, traumatic injury into the mouth, penetrating, and they are going to present with, when you try to open the mouth, they might experience trismus. Sometimes you notice that the floor of the mouth is elevated. They have a very painful, swollen, part of the neck. The tongue falls backwards, so it's very difficult for them to swallow. It's very difficult for them to speak. They drool saliva, and you see the mouth is red, warm, and tender. So something is going down there. So it can lead to death from asphyxiation easily. So that's why you have to be very, very prompt with your airway management in there. Airway management, quick intravenous antibiotics, and evaluate for a need for I&D. Very, very important. So this is just reiterating the symptoms of an individual with sinusitis. We have talked about the fever, the facial pain, the headache. Frontal sinus affected, they are going to have headache. Nasal congestion, discharge. If you do examination, you are going to notice cardinal signs of inflammation around that infected area. So tenderness, erythema, swelling over the particular area. If it is the maxillary sinus, you are going to notice this tenderness, erythema, swelling around the cheek. Very, very classic. So once you see the person having fever, leukocytosis, and purulent discharge for less than a month, you are working with acute bacterial sinusitis. So it's also important for us to remember the fungal sinusitis, which is caused by the muco and the rhizopus. So remember the rhinocerebral mucormycosis. These guys are very notorious, and what you are going to see is bad chronic inflammation that has caused damage to the part of the face. And you are going to see the question stem talking about necrotic ulcers within the palate, within the nasal septum, that can spread beyond the nose to the eye, then to the brain. So, and you are definitely going to get, a background history of immunosuppression, either from diabetes or from, use of medications or HIV, or commonly leukemia, or anything that can cause neutropenia. Most of the time, they can use neutropenia or diabetes mellitus. Just know that background immunosuppression is very important for the mucor and the rhizopus to thrive. And watch out for the fact that you are going to be seeing necrotic ulcers within that face. Very, very important. If you don't see that, I won't advise you to go for rhinocerebral mucormycosis or rhizopus or mucor-induced sinusitis. It will not likely be correct. Watch out for that necrotic lesions. Very, very high. So, acute bacterial sinusitis, acute viral sinusitis is a clinical diagnosis. You don't need any culture imaging to make your diagnosis. No. But you might do culture and imaging for an individual that has chronic disease. You need to know what is going on. If you want to further evaluate an individual with sinusitis, you can do your trans-illumination test, and you are going to see opacification of the affected sinuses. Although this has very low sensitivity, just shine light and notice that area is going to be very, very opaque. So the best test is to do your CT scan. You do your CT imaging, and this is what we are seeing here. So we can see that this is the sinus. This sinus is very good, very clean, very open, because you can see the black hair content here. But here, it is congested. This is exudate filling this part. So it means that this person is having a left maxillary sinusitis. So for people with chronic stuff, we need to do that CT to evaluate for whatever is going on. Is it that this person has an anatomic abnormality, or this person has a mass like malignancy that is occluding the drainage, or this person has polyps that is there, which you expect in an individual that has cystic fibrosis, or whatever is just occluding the drainage of that sinus that is making it persistent for a long time. So your CT imaging can help you. And if there's a need for biopsy, you can easily, go in and take a biopsy or take a, specimen for your culture, just to know the underlying cause of whatever is happening there. So, for treatment, most of the cases of the acute sinusitis are viral. We have made this point already, and they are self-limited. So, but sometimes the symptoms might be unbearable. Even between that 5 to 7 days, it might be very tough for that person. Person just sniffing, having respiratory issues, cannot breathe very well. So you might want to do some symptomatic treatment, which involves giving decongestant. So you can give intranasal oxylmetazoline, which is to help you vasoconstrict the vessels that supplies the sinuses so that you don't have congestion. You can give antihistamine, which are there to help you limit the inflammatory drive, or you can do a nasal saline lavage. Very similar to what we are doing in people with acute pharyngitis, that we are doing like nasal, that we are doing like saline gargle. We are just doing that so that we can limit the inflammation and we can reduce the pain. So you can also give them antipyretics for pain relief. But for individuals with acute bacterial sinusitis, even if you are doing all these things, you must give them antibiotics. You must give them antibiotics. And don't forget the three major organisms we are looking at: strep pneumo, H. influenza, and the Moraxella catarrhale. So the antibiotics we are giving us to cover for them. So you can give amoxiclav. Amoxiclav is very, very excellent. Just like we are giving penicillin for the gas pharyngitis, we are giving amoxiclav here for the bacterial sinusitis for same 10 days. Or you can use your macrolides. Clarithromycin or your azithromycin works for them very well. Or Septrin or fluoroquinolone. Just know one or two. It's fine. The commonest one, amoxiclav, your macrolide, your fluoroquinolone. You are very okay for 10 days. That is all. Then for chronic, you can use similar antibiotics for chronic, but you just need to give it for a longer course. You are not going to stop at 10 days. You are going to give them for at least 3 to 6 weeks. Um, you can also add some adjuvant therapy to help you achieve a quick resolution of the problem by giving the intranasal corticosteroids, the congestant like the oxymetazoline, the antihistamine too. So particularly these are very important if the cause of the chronic sinusitis is from allergic rhinitis, because an individual can have allergic rhinitis, allergic rhinosinusitis that is, associated with perpetual inflammatory drive. They are just there continuously. So you can give your antihistamine. It can help you with the allergic stuff as well as your corticosteroid to limit the inflammatory, condition. And sometimes you might need to do surgery. Particularly, I have the list here. People that have anatomic abnormality, you need to correct it. People that have mass, you need to remove. Mass polyps, you need to remove. People that have fungal infection, you need to go there. You need to debride. You need to remove the necrotic tissue, so that the inflammation doesn't persist. Then you need to give them on the right antifungal, um, agent. And the reason why you are doing all these things is to improve variation to the sinuses. For the fungal one, you are debriding, removing the necrotic tissue. For individual with the structural problems, anatomic obstruction, polyps, mass, you have to remove or correct anatomic obstruction. And sometimes you are not just clear. Whatever is happening there, you might want to go in, through a surgical approach. You obtain cultures and biopsy for histology. So those are the conditions where you might need to do some surgical intervention, particularly if you know the background causes anatomic problems, masses, you might want to go in. If it's fungal, you have to go in to do debridement. So moving on to hemoptysis. Hemoptysis is just when we have expectoration of blood from the lower respiratory tract, usually below the vocal cords. So expectoration of blood below the lower respiratory tract. Expectoration of tract within the lower respiratory tract beneath the vocal cords. So we can say that anything above is epistasis in a way. So it can be divided into life-threatening and non-life-threatening. So what are the major sources of the bleeding? From the pulmonary arteries as well as the bronchial arteries. So the pulmonary arteries are low pressure systems, so the bleeding from these vessels is not life-threatening. But the bleeding from the bronchial arteries is very life-threatening because they are high pressure systems. Don't forget the lungs, they are supplied by 2 arteries, pulmonary arteries, bronchial arteries.
I think someone is trying to catch your attention.
Hello?
Yes, sorry, I don't know. I lost my network, so I missed out on a lot that you said. So I don't know. From the surgery, from the surgical aspect.
Yeah, so what I was just talking about in the surgery is that you do surgery for individuals that have fungal disease. So anybody with fungal sinusitis, you need to do surgery to debride. Anybody that has anatomic abnormality, deviated nasal septum, you need to correct. Anybody that has a mass, polyps, you need to go in to remove it. Sometimes when you don't know what is happening, you might want to go in to take sample for culture and histology. So those are the conditions where you need to do this surgery. So bleeding from the pulmonary vessels, I've said, non-life-threatening because it's low pressure. Bleeding from the bronchial is high pressure, so it's life-threatening. You can classify hemoptysis based on the volume into mild, moderate, severe, or massive. But I don't think it's very, very important for us to actually know it, but we should just know the management of the severe and the massive. That's what is very, very important. So severe is usually when
Sorry,
it's
I didn't get why it's high pressure like the bronchial versus pulmonary.
no the bronchial. It's fact. It's not explanation. Do you understand?
Okay, okay,
Yeah. So the bronchial arteries high pressure, the pulmonary low pressure. So hemoptysis, can be classified into the mild, moderate, severe, and the massive. So severe is when it's between 100 to 600. Massive, when it's maybe the person is bleeding 100 mils per hour, or 600 mils over 24 hours. That's when you can say the person has massive bleeding. So, and most of the time, the massive bleedings are shared with respiratory and hemodynamic compromise. So, 100 mils per hour, 600 mils over 24 hours. But most of the time, we'll talk about life-threatening bleeding. And life-threatening bleeding, you are not attaching any volume. You are just saying somebody have life-threatening bleeding if that person has feature of respiratory compromise or hemodynamic compromise. Maybe the person is having hypoxemia, the person is having distress, but the person is already in shock. That is life-threatening, emergency, and you are going to manage accordingly. So, what are the etiologies for hemoptysis? So just categorize it. The airway, and the airway that we are talking about is just majorly the bronchus. We look at the pulmonary vessel. We look at the pulmonary parenchyma. Then we look at systemic. So that's an easy way to capture all the causes. So most of the time, the bad ones fall within the category of the airway, because you already said it that the high pressure system is the bronchial vessels. So everything bronchial in the airway, that's the one that have very high tendency of causing very massive bleeding. So someone that has bronchitis, chronic bronchitis eroding into the bronchial vessels can have hemoptysis. Someone that has bronchiectasis, we have talked about this so many times. Someone with a bronchial neoplasm, bronchogenic carcinoma, bronchial carcinoid bronchial carcinoid, cancer, somebody with foreign body within the bronchial airway, they can have massive hemoptysis. Now, somebody with pulmonary parenchymal disease, just remember tuberculosis. That's the number one. Tuberculosis is number one for the pulmonary parenchymal disease. Tuberculosis. Remember aspergillosis. Remember aspergillosis. Remember tuberculosis. Then you go to the pulmonary vascular disorder. So the pulmonary vessel now. So look at anything that can increase the pressure within the pulmonary vessel. For example, somebody having congestive heart failure, left-sided heart failure. You're having blood that is pulling back into the pulmonary vein, pulmonary venous congestion. They can easily rupture those vessels and they can start having hemoptysis. Somebody having mitral stenosis, they can have pulmonary venous congestion and elevation of the pulmonary capillary pressure, and they can easily have hemoptysis. Someone that have arteriovenous malformation of the pulmonary vasculature, someone that have a PE, they can have hemoptysis. Someone that has bleeding disorder, that's systemic. Bleeding disorder from any cause. Maybe the person is on anticoagulant, person has a DIC, anything. They can have a P. So just look at it. The bronchial airway, bronchial, the lung parenchyma, the pulmonary vessel, and systemic. You'll be able to have a lot of points to take out. So the commonest cause is infection. So somebody having bronchiectasis, commonest is infection or tuberculosis. Then lung cancer. Then lung cancer. So you must rule out all these ones in your investigation. So, for example, you have to assess for the risk factors of lung cancer in patients with heavy smoking history. You want to know how many pack years, how long have they been smoking, when did they stop, any weight loss and the likes. So rule out life-threatening hemoptysis by checking for the hemodynamic parameters, the blood pressure, the pulse rate. You look at the airways, person, breathing well, or the person is experiencing difficulty, so that you know what to do next. So any volume loss, which is associated with airway compromise, impaired gaseous exchange, and hemodynamic instability, that is what we call life-threatening hemoptysis. That is life-threatening hemoptysis. So let us go to the algorithm before we come back. So they're rushing an individual that's having hemoptysis, person's having bleeding from the lower airway, and you have a low suspicion for oropharyngeal disease. You have checked the mouth, you know that there's nothing in the mouth, and you have a low suspicion for GI issues, and you are able to establish that the person is having life-threatening parameters, massive bleeding, more than 100 ml per hour, respiratory distress, hemodynamic instability. You want to proceed in your algorithm. Okay, the next thing is ABCD protocol. Now, look at the airway. Can the person able to communicate with you? Can the person talk? So that you can assure that, okay, this airway is patent. If the airway is not patent, you quickly want to secure that airway. I think I have the algorithm here. So you want to secure the airway, you want to do your endotracheal intubation. You want to place the person on lateral decubitors. And what you are doing is you want to do lung isolation. Because just imagine that somebody is having bleeding within the lungs or the bronchial airway or whatever. At the end of the day, most of that blood is going to be gravitating to the lungs. So let's say that the bleeding is happening into the right lung. So what you are going to do is that you are going to place that person on the right decubitus position because you want to isolate the left lung from the pathology. And most of the blood is going to be pulling within the right lung, and they will not affect the left lung so that the left lung can continue with the ventilation. Then you want to check for the oxygenation status and breathing. If the person needs oxygen, you give oxygen. Then the next one is circulation. This guy is bleeding massively, so they will definitely need some hemodynamic support. So you need to give them immediate fluid resuscitation with like normal saline, dextrose saline. Then emergency blood transfusion immediately. Then you can administer some agent to help you achieve hemostasis like tranexamic acid or desmopressin in individual with renal failure. Then you now want to go in with your bronchoscopic hemostatic techniques. So after you have done your ABCD, the next thing is to try to arrest the bleeding temporarily by doing your bronchoscopy. So what are you planning to do your bronchoscopy? You can do a physical tamponade with your bronchoscopy. You can do a thermal ablation of the vessels that are bleeding, or you can inject some drugs like tranexamic acid or epinephrine. Epinephrine is a potent vasoconstrictor. So you can inject epinephrine with your bronchoscope to achieve a temporary hemostasis. Then later, you can now do your definitive approach. And your definitive approach is to do bronchial embolization. So you want to embolize those vessels to arrest the bleeding, because this approach is safe, minimally invasive, and it's fast, rather than doing surgery. But there are some conditions that you must definitely do surgery. We'll come back to that. But if the person,
Sorry, Doc. I'm trying to, like this one you showed. Is the same thing with this algorithm, right? Or maybe more
yeah,
in
yeah,
details?
look at it. So, life-threatening features: massive bleeding, respiratory distress, hemodynamic instability, they are present. Either one of them is present. You have to go through this approach. ABCD: secure airway, breathing, circulation. The same thing I've said. Secure the airway, intubate, lateral decubitors to isolate the lung and preserve the functional lung. Check breathing, give oxygen, circulation, administer intravenous fluids, emergency blood transfusion. Then your temporary measure, which is to do bronchoscopy. And what are those things you want to achieve with your bronchoscopy? You want to do tamponade, you can do thermal ablation, or you can administer epinephrine, right? Then, before you now do your definitive treatment, which can be interventional radiology embolization or lung resection, which is the surgery. But I've said it's not in all conditions that you are going to do surgery. It is not, maybe somebody has arterogenic, maybe the cause is arterogenic rupture of the pulmonary artery from right arch catheterization, or somebody has ruptured pulmonary aneurysm, you have to do surgery. Or if this person has bleeding from a lung cancer that is resectable, or from TB, or from aspergillosis, you have to resect. So I'm going to show us the surgical indications now. Why,
Sorry,
if
so does this mean that, sorry, no investigations, like you just go to like emergency
yeah,
approach
look at it.
once there's, uh-huh, okay.
When you are at your circulation, that's where you do your blood collection, right? You know, the way we do it. Airway, breathing, circulation, you want to give fluid, you want to give blood. That's when you are setting line. That's where you are going to collect your sample for the blood. I'm going to go back up and show us what we are going to check for. So I just want to break down this stuff first before we go back up and see the investigation we are going to do. So if none of these guys is present, if there's no massive bleeding, no hemorrhagic distress, no hemodynamic instability, then you can now do your labs. You know, do your labs to look out for whatever is causing the stuff. You want to do your grouping and cross matching. You want to do your CBC. You want to do your coagulation studies to see if there's any systemic cause of bleeding. You want to do your chest x-ray, because chest x-ray can give you a rapid overview of whatever might be going on. Maybe this person has bronchiectasis, this person has lung cancer. You can easily identify on your x-ray. This person has PE, although PE might not come up, on chest x-ray most of the time. If this person has maybe a foreign body impacting there, you can see it on your chest x-ray. And some of them, you might need to further proceed with your CT scan. But you can only do all this if this patient is already stabilized. So CT, chest CT, to further identify if there is bronchiectasis, to further, identify if this person has maybe a lung cancer. You can define the cancer well with your chest CT. Then, if you don't find anything here, your labs, X-ray, CT, clean, you can proceed to do bronchoscopy. So, bronchoscopy, if you get a normal imaging findings. So, if you find anything on your bronchoscopy, you treat accordingly. But what is going to determine which one you are going to go first is this parameter. If this person is having life-threatening feature, you have to go through the ABCD approach before you start talking about investigation. Stabilize that person. Arrest that bleeding. If the person is not having any one of these, now start with your investigation, your lab, your x-ray, your CT. If you don't find anything here, you have to do a bronchoscopy to see what is inside. So, whatever you find there, that is what you are going to treat. So that's the way it works. So what are those things you want to do on your
What lab would you like to do?
so
Oh,
you
okay,
you
don't
want to
worry.
do your
Finish.
CBC. This person is bleeding. You want to know the coagulation status. You want to know the blood count. You want to do coagulation studies, your PTT, your PT, INR, to see if there's any problem with the coagulation parameters. You want to do analysis. Analysis can help you rule out some of those vasculitis, like somebody having Wegener's. So you are expecting a nephritic picture there. You can also do some rheumatologic workup, because some of those rheumatologic disease can also cause it. Like an individual having SLE, they can have lupus pneumonitis, which can easily present this way. So that's the way it goes.
Sorry, the comment you made on about the lateral decubitus position, I
Yeah.
didn't quite get that with the unaffected lung something. Can you explain that again?
Okay. So there's bleeding into the right lung. The bleeding is going to the right lung. So what you are going to do is that you are going to place that person on that right side, so that all the blood, gravity, is going to be, like the blood is not going to be moving to the left side. Because if you place the person on the right side, that blood is going to be gravitating to the right side only. So it's going to eliminate, shift to the left side, so that left side will be prevented the bleeding is not going to go to the left side, and the oxygenation, ventilation function can be happening in the left side.
Oh, okay. But how do you ascertain the side clinically, since except you've done investigations, right?
Yeah.
But this position is like the first things you do. How sure will you be of which side to?
Yeah. Maybe after you do your scope, whatever you see, you identify the lungs that is affected, you can now gravitate towards that side. Or maybe your chest examination, the side that is affected when you are trying to do your examination, you know that, okay, it is this lung that's kind of having issues, you tilt to the other normal side. So examination too can help you. So that's the way it works. So moving on to pleural effusion. Pleural
So
effusion
that
is
means
just
that means you lie the patient on the opposite of the
no,
affected lung. The patient
Same
lies on
side,
the
same.
side of
no. You lie
lies
the
on the same
patient
side
on the same side.
of
You
vision.
are going to lie the patient on the same side. Okay, so pleural effusion is just abnormal accumulation of fluid in the pleural space. We know the pleural space is just space in between the visceral and the parietal pleura. So we can classify it into two, the transudative and the exudative fluid. The pathophysiology of transudate is imbalance between oncotic pressure and hydrostatic pressure. So the hydrostatic pressure is the pulmonary capillary wedge pressure. So either you have an increase in the hydrostatic pressure or a decrease in the oncotic pressure, because your hydrostatic pressure is trying to keep fluid out of the vessel, while your oncotic pressure is trying to keep fluid within the vessel. So it means that if you have more hydrostatic, you are going to have more fluid shift. If you have less oncotic, you are going to have more fluid movement. So it's just pressure imbalance that's causing transudative. While for exudative, it's due to any inflammatory problem that can lead to increased vascular permeability. Maybe inflammatory, maybe traumatic, anyone. The vascular integrity is destroyed in exudative effusion. So I know we already know this. So once they bring in the patient, we have done our examination, we already identified where the problem is. We want to do our diagnostic thoracocentesis and obtain sample from that pleural space and subject it to some tests. And this brings us to the light criteria, where we want to check for the pleural protein, the pleural fluid LDH, the pleural fluid protein LDH, and the serum protein and the serum LDH, and we want to compare them. So you have to get the ratio of the pleural protein to the serum protein, the pleural LDH to the serum LDH, and also compare this pleural LDH to the serum LDH. So if the pleural protein over the serum protein is more than 0.5, it's in keeping with exudative, because it means you have more protein leaking into the pleural space from the serum. Kind of, that's what it means. So, and if it's transudative, protein will not leak because the vascular integrity is normal. It's only fluid that's going to move. So if the pleural protein is over the serum protein is more than 0.5, is in keeping. If the pleural LDH is more than the serum LDH, is also in keeping. The value is more than 0.6, and the pleural LDH is more than 2/3 of the serum LDH. So I know we know this algorithm very well. You just need one of these to be met for you to categorize it into exudative. Just need one. Just need one. So if none of this is met, it is
Please,
transudative.
sorry, I wanted to ask, is this a plus sign or over sign? Because
Yeah, this
I
is
don't know if it's my
division.
own book.
This is division.
Is a mistake or what?
Division.
Yeah, okay, it's division.
Yeah. So if it's transudative, you have to delineate. Is it what are we working with? Is it any condition that's decreasing the oncotic pressure or anything that's increasing the oncotic pressure? And you can only know with the associated symptoms. So somebody having features of heart failure, this is heart failure, somebody having renal disease, they will have increase in the hydrostatic pressure, pulmonary embolism at the early stage. It is increase in pulmonary pressure that is causing the problem. Why people that have reduction in oncotic pressure are people like having liver issues or nephrotic syndrome, because these people, they're having problem with the production and the excretion of protein. Cirrhosis is not producing protein. Nephrotic syndrome, they are losing protein. So both of them will cause a drop in the oncotic pressure, and that can easily facilitate transudative loss. Why people with heart failure, people with CKD, people with early form of pulmonary embolism have increased hydrostatic pressure that drive fluid into the pleural cavity. So you have to treat the underlying cause. That is what you need to do. Most of the time, you might not even need to be draining the effusion. Just treat the underlying cause. Everything is going to solve. Why for exudative? You need to find that underlying cause, treat it, and also drain whatever effusion that is there. So I don't really know the reason why we are categorizing between thoracic or extra. I feel it is not necessary. Yeah, that's not necessary to me. But we should just think about inflammation for exudative. Inflammation or trauma. So anybody that has trauma would fall under the exudative category. Infection. Somebody has pneumonia. Pneumonia can progress and form a parapneumonic effusion. Inflammation spread from the parenchyma to the vessels, so leading to effusion into the pleural space. Somebody can have TB and have effusion. Somebody can have a lung cancer. Cytokine release can destroy the integrity of the vessels and lead to the leakage of fluid into the pleural cavity. Autoimmune disease, inflammation. RA, typically SLE, most of the time RA, rheumatoid arthritis, very, very important. Drugs, most of those chemotherapeutic drugs, Bosulfan, cyclophosphamide, and drugs like amiodarone, they can also destroy the integrity of the vessels and lead to bleeding, or movement of fluid and proteins. Pulmonary embolism at the later stage, because pulmonary embolism initially is going to cause a block, pressure buildup, transudative. Later, that area is going to become kind of ischemic and infarcted, and cytokines will be released, vascular damage, fluid leakage. So late part of PE is exudative, early is transudative. Shallow thorax, someone that has traumatic injury to the thoracic duct can have leakage of, chyle into the pleural space, and that's going to have a very high triglyceride content. Hemothorax from trauma, bleeding into the pleural space. Those are the intrathoracic ones. Extrathoracic, they are coming from outside the lungs, from outside the thorax. So, for example, it can be right-sided, like in people with MEG syndrome. So, MEG syndrome is just triad of ovarian fibroma, ascites, and right-sided pleural effusion. So, it's more common on the right because the transdiaphragmatic lymphatic channels are bigger than on the right than on the left. So that means that they have a very high chance of draining some of those acidic fluid into the right side because their own diameter is wider. Endometriosis occurring in the right, we don't know. I don't know. So maybe we can do our research and get the reason, but I don't know the reason why it preferentially goes to the right. While for the left side, we can think of things like pancreatitis. Pancreatitis, because just like when we are doing ARDS, pancreatitis is a very severe condition that is associated with widespread inflammatory process, release of cytokines. So it can lead to a widespread inflammation with formation of inflammatory exudate that can be confined in between the stomach and the transverse colon. So it can lead to release of amylase, lipase, lysine, fat, everything around the surrounding structure. They are triggering inflammation around. They are structures, and most of the time, the inflammatory exudate is going to be confined as abscess between the transverse colon and the stomach, and from there it can easily rupture into the left side of the lungs. Esophageal rupture too can be a cause of left-sided pleural effusion because, particularly the distal part of the esophagus. The only way to remember that is that the distal part of the esophagus continues with the stomach, and we know that the stomach is situated on the left. So it means that if somebody has distal esophageal rupture, they can easily have, extravasation of the content into the left side of the lungs, which is causing the pleural effusion. So these people now they need to get further workup. We need to obtain that pleural fluid and subject it to further analysis. So we want to do a biochemical workup, we want to do a microbiological workup, we want to do a cytologic workup, because you don't know whatever is causing it. So cytologic workup will help you identify the cells that are there, particularly malignant cells. Your biochemical workup will tell you, will give you idea of if it's infection. To maybe you are checking for adenosine deaminase, which is going to be elevated in someone that has tuberculosis. You are looking at the glucose level, you are looking at the protein level, you are looking at the pH. For the microbiological, you want to do a gram staining, you want to do acid fast staining. Then also you want to do some immunologic or rheumatologic workup. You want to assay for all those antibodies, ANA, to rule out SLE. You want to do your rheumatoid factor for rheumatoid arthritis. You want to do your anti-citrullinated peptide for rheumatoid arthritis. So, from this list, you can get an idea of whatever you want to check for. Infection, your gram stain will help you. Your cytology can also help. For neoplasm, your cytology is going to help you. Autoimmune rheumatologic workup, PE, drugs is just history. Pulmonary embolism, you can get this from either you do your D-dimer, or you do your CT angiography, depending on the presentation. So,
Dr. Babawale, we didn't get you for some time. I mean,
Yeah,
your network.
I was thinking it's just me because you were breaking. We couldn't hear you for a while.
what was the last thing we heard? Like,
You were still talking about the intrathoracic.
Okay. I was talking about because I was talking about the workup.
No, we didn't get that part.
Eh?
I did that part.
Wow. So, I can't even remember. Okay. Just what I was trying to talk about was the fact that you need to do workup for people with this condition. So I said the workup is going to give you idea of what you are dealing with. So you need to do biochemical workup, you need to do cytologic, you need to do microbiological, you need to do rheumatologic, so that you can narrow down the cause. So you obtain a portion of the pleural fluid and you do the test. So for example, infection now, that's going to be microbiological, your gram staining and culture. Tuberculosis, if you are thinking tuberculosis, acid fast, staining, and then culture too. So for your biochemical, you want to check for the level of the glucose, you want to check for the level of the protein, you want to check for the pH, because they are going to give you an idea of what you are working with. For the cytological, you want to look at the cells that are present there. Are they malignant cells? That can help you for malignancy. You want to do rheumatologic workup. So people that you are suspecting RF, rheumatoid arthritis as the cause, you want to check for those factors, like rheumatoid factors, like anti-citrullinated peptide. SLE, you want to check for antinuclear antibody, right? Then most importantly, TB, you want to check for adenosine deaminase. Very, very important in TB. Adenosine deaminase is elevated in TB.
Why?
So
Why?
I don't know. It's just released. It's just releasing TB infection. I don't know the reason why it is elevated. So it's just one of those. It's just like what is this called now? Okay, that doesn't work that way because this one is a component of that organism, but it's just elevated in individual with TB. Maybe from the organism, I can't really say, but it's specific for tuberculosis. So, yeah. So I think we have talked about the the list, and we need to know that people with chylothorax, you are going to notice that the level of triglyceride is going to be elevated. So that should raise suspicion for that. So how will they present? They are going to present with dyspnea, pleuritic chest pain. Dyspnea because the effusion is going to be compressing on the lung, so they are going to have difficulty breathing. And during breathing, you are going to notice the inflamed uh, pleural curvings. They are going to be, rubbing on one another, leading to this pleuritic chest pain during when they are breathing, and they can also have cough. If you do your examination finding, there's going to be dullness, notes on percussion. The breath sound is going to reduce, particularly over the side that is effused. And don't forget the frictional rub. This frictional rub is, very specific for them. They have this, although, yeah, this is pleural frictional rub, not pericardial. So if it's pericardial, you can think of pericarditis. This is pleural, and you can delineate them because this one, you are going to hear the squeaking sound, during breathing. That's when you are going to hear it. But for the pericardial one, you tend to hear it when you tell them to stop breathing. That's when you hear that one more. So this is just comparing the examination findings for an individual with lobar pneumonia, pleural effusion, and pneumothorax. So on percussion notes, it's going to be dull for consolidation and effusion. They used to talk about stony dull for effusion, but the USMLE don't really talk about the stony dull of a thing. So everything is dull to them. For pneumothorax, the note is going to be hyperresonant because of the fact that it's air that is there. For consolidation, because it can conduct sound faster because of the increased density. So tactile parameters is high, and that's why the bronchial sounds are heard. There's increased breath sound, or the sound is said to be bronchial. While for the other ones, it's going to reduce. Voice transmission is going to be high too in consolidation. So you hear the egophony, the bronchophony. I've talked about this. Egophony, we tell the person to pronounce E, you are hearing hey. So for pleural effusion and pneumothorax is dropped, is reduced. You typically hear crackles in people with pneumonia, but it's absent in pneumothorax and pleural effusion. So the best initial test to do to make diagnosis of pleural effusion is to do a chest X-ray. That's the first thing you do. You do a chest X-ray, and part of the examination finding is blunting of the costophrenic angle as well as presence of the meniscus sign. So let's just see, though I know we know it, just to show us again. Pleural effusion X-ray. That's, yeah, so this is you can see the meniscus sign here, the homogeneous opacity downward. So that's what we expect in an individual with pleural effusion and blunting of the angles. So the angles are going to be blunted. Of course, it's already blunted. We don't have the costophrenic angle. This one is still here, but this guy is blunted. So
Sorry, Dr. Babawa, there was a question I saw. The next.
hello, what did you say? Hello, can anyone hear her? Hello, are we there?
Okay.
Hello.
We can hear Dr. Bawali. We can hear
I
you.
can hear you. Can you hear me?
Yes, I can't. What did you say?
I was saying that there was a question I saw something about layering of fluid. I didn't know that term before for effusion.
Yeah, I'm not
So
done. I'm still going to mention it. That's
okay,
the
is it
next thing
coming to that? Okay, I thought it could be seen in those X-rays you showed. That's why I asked it. All right, thank you.
Yeah, so that's why you tell them to do. You place them on lateral decubitation. So you are going to see layering of the fluid on lateral decubitus film. So sometimes you might not get all this blunting, but once you see that statement, layering of fluid on lateral decubitus is very important for a free-flowing effusion. Sometimes it might not layer when there is loculation, because loculation means that the effusion has fixed, it has adhered to the wall. So you just be seeing septations, you'll be seeing compartmentalization, and you notice that you will not be able to gravitate that fluid by the time you are telling the person to, shift to the lateral decubitus, because the effusion has kind of gummed itself to the pleural space. But lateral decubitus view is very good. You can easily see effusions that are even small, and then you can assess for loculation. So once you see evidence of loculation, you should, think about a more severe form of effusion. Maybe somebody's having empyema, somebody's having tuberculosis or pneumothorax. Those are the commonest cause of loculations. So once you have, identified your effusion and your X-ray, the next thing to do is a diagnostic thoracocentesis. So you obtain, particularly in people that have new effusion. So that's the first time you are seeing that effusion. And in cases of bilateral effusion, you don't take a sample, because most cases of bilateral effusion will come from conditions like heart failure. If you look at heart failure is just pulling of blood in the lung. So it means that if the pulmonary vein is affected, it's definitely going to affect both sides of the lungs. So it's going to be bilateral. So you might not want to, bother doing your thoracocentesis, you just manage your heart failure. But sometimes if you are seeing bilateral effusion and the person is having fever, chest pain, or all those atypical signs, which is not in keeping with heart failure, you can go ahead and do your thoracocentesis. So you now analyze your what you get, whatever you get, according to the light criteria. So if you get any one of these, you are working with an exudative effusion. So part of your biochemical parameters, aside your LDH, your protein, your pH too is important. It's going to also help you. Ideally, for people with transudative effusion, because the metabolism there is not very high, inflammation is not really high, so they don't generate waste product of metabolism that are acidic. So the pH is within the normal to alkalinic range, like 7.4 to 7.55. But for people with the exudative process, their pH is less than 7.4. And the lower the pH, the better it is. So we'll talk about this when we start talking about the complications now. So just know that for exudative is less than 7.4, and for transudative it's more than 7.4. So these are the other stuff you want to do: the glucose, the amylase, and amylase is going to tell you that if amylase is elevated, anybody knows what we are going to be thinking of.
Pancreatitis.
So start thinking about pancreatitis, cytology, malignancy, cell count, bacterial, stuff, infection, culture, tuberculosis, pneumonia, gram stain, same thing, AFB, tuberculosis, adenosine deaminase, tuberculosis, tuberculous antigen 2, rheumatoid factor for rheumatoid arthritis, CCP for rheumatoid arthritis, and now for SLE. So there are some complications that we also need to know, like parapneumonic effusion and empyema. So parapneumonic effusion just means effusion with a background lung pathology, particularly pneumonia, most commonly, or a lung abscess or bronchiectasis. So anybody that has bronchiectasis, lung abscess, or pneumonia that develops an effusion, you call that a parapneumonic effusion. Most of the time it follows pneumonia. So an individual can have uncomplicated parapneumonic effusion, complicated parapneumonic effusion, or empyema. So empyema just means complicated parapneumonic effusion with pus. So that's it. So uncomplicated parapneumonic effusion means there's an effusion there, but it doesn't contain bacteria. Complicated parapneumonic effusion means there's a effusion there, there's bacteria. Empyema means there's effusion there, there's bacterial colonization, proliferation, death of bacteria with associated pus formation. So what we just basically need to look at, to differentiate between all this three stuff is to look at the appearance first. I've said it that there's no bacteria in uncomplicated parapneumonic effusion. For complicated, there's bacterial innovation, but there's no pus. For empyema, there's pus. So for the appearance, for uncomplicated, it might be clear or cloudy, but most of the time you can get it clear. But if it's cloudy, you should raise your suspicion for complicated parapneumonic effusion. Bacteria will make it cloudy. But for empyema, it's going to be purulent. Yeah, purulent foul smelling. When you do your pleural fluid analysis, the glucose and the LDH ratio is going to be in keeping with what you have for normal exudative. Glucose is going to be down. LDH ratio is going to be more than 0.6. Yeah, but your pH will help you, because we have said that the pH cutoff for effusion, which is exudative, is less than 7.4. But because of the fact that complicated and empyema, they have bacteria in that exudate, in that effusion, the bacteria is going to be undergoing serious metabolism, metabolizing all the glucose, everything that is there, formation of lactic acid that will drop the pH further down. So it's going to definitely less than 7.2 for complicated and empyema. Why for parapneumonic is going to be more than 7.2 but less than 7.4. And the glucose can be normal or decreased depending on the extent, of the inflammation in the uncomplicated. So the pH is the major thing. Just look at the pH quickly, separate, it, and you move. The pleural fluid gram stain and culture.
Sorry, Dr. Paul, did you say the pH in uncomplicated is more than 7.2, but less than 7.4?
Yeah.
Or greater than 7.4?
Less than 7.4.
Okay.
Look at this. Exudative effusion have a pH of less than 7.4, right? Parapneumonic effusion. What kind of effusion do you think it is? Do you think it is an exudative? It's caused by inflammation associated with pneumonia, so definitely it's going to be less than 7.4. But it is not going to be less than 7.2, because I said it that if bacteria are there, they are going to metabolize the glucose and generate more acidic products. But because here you don't have bacteria at all, so there's nothing to further bring down the pH. So it's going to still be more than 7.2, but it will not be more than 7.4, because the 7.4 defines it as exudative. Less than 7.4 defines it as exudative. For you to now know the grade of how exudative it is by looking at how low is this pH. If it's now less than 7.2, you know that definitely there's bacterial involved in this process. But because there's no bacterial involved in uncomplicated, it will be more than 7.2 but less than 7.4. So that's what I'm saying. So for the pleural fluid gram stain and culture, it's going to be negative for uncomplicated. There's no bacteria there. You cannot gram stain and culture anything. For uncomplicated too, it can be negative because the bacterial load is not as high. So you might get, a false negative reading for complicated parapneumonic effusion. But in empyema, definitely you are going to have a positive value. So what do? You treat with antibiotics only for the uncomplicated, but for the other two, you have to give antibiotics and you drain with your chest tube. So that's the modality of treatment. Recurrent effusion is also another complication aside these three. And what you have to do is to do pleurodesis. When it is recurrent, you obliterate that pleural space, you join them together so that there's no space again, for fluid to be accumulating. So complicated parapneumonic effusions and empyema definitely require chest tube drainage with antibiotics cover. So moving on to pneumothorax. Pneumothorax is just a condition where we have hair accumulating within the pleural cavity, not fluid now. three categories, three types. The primary spontaneous pneumothorax, meaning primary, meaning there's no problem with the lung. Spontaneous, meaning there's no trigger. And pneumothorax is air within the pleural cavity. There's no trigger, there's no damage to the lung, and we have, air in the pleural cavity. So this is very, very common in people that are tall, that are thin, and young. So basically, lanky people, you are tall, you are thin, you are young. So they tend to have formation of, maybe due to elongation of the lungs, it's kind of facilitate formation of subpleural apical blebs. So blebs are just like pocket of hair within the pleural membrane, which can easily rupture and lead to hair movement into the pleural cavity. So that's a form of primary spontaneous pneumothorax. Why secondary pneumothorax basically follow diseased, lung tissue. And you have to think about COPD, number one. COPD is associated with severe lung trapping, hair trapping within the lungs. So they can easily form pockets, of hair as the blebs, and the blebs can rupture leading to the pneumothorax. People with the PCP pneumonia too, they form blebs. Very, very common in them. They can have pneumothorax. People with TB can have rupture of the cavities, the caseous necrosis, they can rupture, and it can easily allow hair to track into the pleural cavity. Then finally, it can be iatrogenic. So just from inside to outside, Inside, you are trying to place in, should I say it that way? Let me just say it anyhow. Somebody trying to do bronchoscopy, trying to take biopsy of the lung, mistakenly puncture the parietal pleura, you can have a hole created allowing hair to track into the pleural cavity. Somebody trying to do diagnostic thoracocentesis from outside, you can puncture the parietal pleura too, mistakenly, and hair can also track into the pleural cavity. Somebody trying to place line into the subclavian vein, it's very close to the lungs. So from up, they can puncture that, mistakenly puncture the parietal pleura, and then you can have entry into the pleural cavity. Or somebody that is on PEEP, and the PEEP is too much, like maybe like more than 10, and it causes barotrauma, and there's rupture of the alveoli, you can have hair tracking into the pleural cavity, leading to pneumothorax, iatrogenic. All of these can get complicated and lead to tension pneumothorax. So tension pneumothorax just means you have a one-way valve. That opening that has been created is allowing hair to move in during inspiration. So it's allowing hair to move in during inspiration, but it's not allowing hair to get out during expiration. So that is tension pneumothorax. So at the end of the day, the air is going to be building up, and it will compress that lung tissue first. When it compresses the lung tissue, you see that the lung tissue becomes small. It will look something like this. This is the remaining of the lung tissue for this person. This, what we are seeing here, is what is left of the lung tissue. This is it. What is here is the pleural cavity filled with hair, making it hyperlucent, compressing on the lung. So that's why we can see this shape. This is the lung. Then later, it's going to cause a shift of the mediastinum, and because of the fact that the SVC is part of the component of the mediastinum, so it can easily kink the SVC and prevent venous return to the right side. So that person is going to suffer immediate hypotension, leading to cardiac arrest. So we can make diagnosis of tension pneumothorax clinically because there are so many examination findings that is going to be a pointer to that. By the time we start examining, we see that the chest that is having that pneumothorax is not going to be expanding as the other one. By the time we start our percussion, we are going to notice hyperresonant notes there. By the time we touch the trachea, we notice that the trachea is deviated away from the side of the pneumothorax, because the side of the pneumothorax is going to be pushing the trachea to the other side. Then, what else again? Of course, we are going to be, by the time we measure the blood pressure, it's going to be hypotensive, By the time we check the JVP, it's going to be elevated. So we can easily say that what we are working with is an individual that has tension pneumothorax. So we can now continue the investigation by doing chest X-ray. Ideally, you don't do chest X-ray after you have made your diagnosis. So once you make your diagnosis, you just do your treatment, your needle decompression immediately. But if you don't know that is tension pneumothorax and you do chest X-ray, what you are going to see is just an area of hyperlucency, just like we have here. You can see the compressed lung tissue. There's going to be obliteration of the vascular markings. You can't see the vessels again. Then there's something we call the visceral line that is going to be very prominent. You are going to see the visceral pleural line. It's going to come out as a thin, fine line like this. Can we see this stuff? Can we see this line?
No.
Look at this
Yeah.
arrow. Can you see this
Zoom
arrow?
it.
Oh, okay, with the arrow. Okay, yeah.
This is the visceral pleural line that's going to be very conspicuous. Sometimes at ICU, we can do a bedside ultrasound and we can also see the tension pneumothorax with our bedside ultrasound. In fact, that's very high specificity and sensitivity. I have not seen one before. I don't know if anybody have seen anyone before. So this is more like a CT image showing the tension pneumothorax. We can see this lung. Can we see this small lung here? It's already getting compressed. You can see the area of the hair filling the pleural cavity, compressing on these lungs, as opposed to this one. So tension, this pneumothorax. We can see the tracheal deviation here. We can see the lung compression. We can see the hyperlucency. So those are all those things we need to look at. You can see that the lung marking is prominent here. You can see that it's clean, not thin. Is here. That's pneumothorax. So you have to place a needle decompression first, to salvage that process before you now do your chest tube placement. They are definitely going to still get chest tube placement because they are unstable. You need to give them chest tube at the end of the day. So the treatment for tension pneumothorax, we have said it, immediate needle decompression first at the second intercostal space, mid-clavicular line. And then you put your chest tube later at the fourth intercostal space, anterior axillary line. Then for people with small pneumothorax, particularly less than 2, so there are ways by which they calculate the size of the pneumothorax. Those are like radiographic measurement. We don't really need to know it. There are so many methods. But if they tell us that, maybe in our exam, if they tell us that the size of the pneumothorax is 2 or less, so we might not, and we are not working with tension pneumothorax. So it's just a simple pneumothorax. We can just observe and give supplemental oxygen if it's needed. It will definitely reabsorb spontaneously. But if it is large, more than 3, and the person is symptomatic, we need to do either a needle decompression or a small ball chest tube placement. For large, which are the ones more than 3. But for people that are unstable or they have recurrent pneumothorax, you have to put a chest tube there. Just put your chest tube there, to prevent it from happening. For people with recurrent pneumothorax, you have to put a chest tube. People that have tension pneumothorax, they are going to be unstable, so they are definitely going to get a chest tube too. So that's all about the management. Just know that for small one, less than 2 or equal to 2, you can do observation. That's the only stuff that is important. And tension pneumothorax, you do need to first before putting your tube. So moving on to the pulmonary sleep disorders, we are going to be starting with the obstructive sleep apnea.
Sorry for with pneumonic effusion, the uncomplicated. Do you need to put a chest tube, because they said with the complicated one you must put a chest tube to drain?
No, uncomplicated, you don't put chest tube. Just give antibiotics.
Just give antibiotics. So even if the pleural effusion is large.
Yeah, just give antibiotics because it doesn't contain bacteria.
Okay.
So, obstructive large sleep apnea. So, obstructive sleep apnea just means a sleep-related disorder that is associated with reduction in airflow during sleep due to obstruction of the airway. That is it. So, the etiology might be central, secondary, or mixed. Central, from individual that have stroke. You see, what we just need to understand here is that the airway, particularly during sleep, is controlled by the tone of the pharyngeal muscles. So, if the pharyngeal muscles contract, there's going to be widening of the airway diameter, and the person can easily take in air during inspiration, expiration. But if the pharyngeal muscles are weak and they are relaxed, there's closure of that airway. So it's kind of paradoxical in thinking, but that's the best way to know it. So if they are weak, they are not contracting, they will close the airway. But if they contract, they will open the airway. Very easy. So people with central conditions like stroke, or people that are on sedatives, people that have taken alcohol, there's kind of relaxation of those muscles, because the tone of those muscles is going to be calm in them, and there's going to be relaxation of pharyngeal muscles, parapharyngeal muscles, leading to reduction in the diameter of the airway, causing airway obstruction, particularly when they are sleeping. Because we remember that during sleep, particularly during the REM, the tone reduces. So that is further going to worsen the problem when they are sleeping. Why people with the secondary one, that one is very straightforward. There's already like a mass, or there's something that is obstructing inflow of air when they are sleeping. Either the person has adenotonsillar hypertrophy, or the person is obese. So people that are obese, they have a lot of fat mass in the neck that is reducing the diameter of the airway, increasing airway resistance, so they cannot easily take in air. Or people with adenotonsillar hypertrophy that is occluding the airway, they can experience obstructive sleep apnea when they are sleeping. The risk factor is very high in male sex, because it's believed that male sex tends to have a larger neck diameter, and at the same time they also engage in some risky behaviors like smoking. Smoking can be a risk factor for obstructive apnea because of airway inflammation, increased mucus secretion, narrowing of the airway, and increased airway resistance. So older age is actually weakening of the parapharyngeal muscles. They can contract very well, airway diameter reduces. Craniopharyngeal abnormalities, people with macroglossia, people with crowded pharynx, they can have obstructive sleep apnea. People with adenotonsillar hypertrophy, people that use sedative. So sedative work together with the central cause. Then smoking, just like I explained, upper airway inflammation, mucus production. So that is that about the obstructive sleep apnea. There's obstruction. It can come from central or secondary. Central because of reduced tone. Secondary because of obstruction. Maybe from a mass, fatty infiltration, or from adenotonsillar hypertrophy. So what are the cardinal features? The abnormal respiratory patterns that we observe. So we observe 3 abnormal respiratory patterns during sleep for people with obstructive sleep apnea. 3. Number 1, apnea. Number 2, hypopnea. Number 3, what we call the RERAs, the respiratory effort related arousal. So what is the apnea talking about? So I have it defined here. Apnea is when you have complete or near complete, close to 90% cessation of inspiratory airflow for more than 10 seconds. So it's not that the person is not breathing. The person is breathing, but air is not entering because of obstruction, right? That's the problem. Because of obstruction, this person is not hypoventilating. Please don't mix them up. The person is trying to but the air is not entering because of the obstruction. So when you have complete or near complete cessation of that inspiratory airflow for 10 seconds or more, that is apnea. Hypopnea is when you have airflow reduction by 30% for more than 10 seconds, not 90, 30 for more than 10 seconds in combination with desaturation by more than 3% from baseline or sudden arousal. So there's 30% decrease, in the airflow that is entering the person's airway for 10 seconds. And in addition to that, there's 3% desaturation or sudden awakening or arousal of that person. That is hypopnea. Then the last one is now what you call the RERA, the respiratory effort related arousal. So this happens when somebody suddenly wakes up, from sleep due to hyperventilation or obstruction, but the person is not within the range of apnea or hypopnea. So let's say
Please,
that
what do you call the last one? Can you come again, please?
okay, let me show you what we have. I think I have it here. So RERA is when you have arousal from sleep due to increased respiratory effort or reduced airflow for 10 seconds without significant hypopnea or apnea. So what we are saying here is that in RERA, which is respiratory effort, what is this respiratory effort? Increased respiratory effort. They start, and they wake up. Why? They wake up because they are
due to increased respiratory effort.
there's increased respiratory effort or there's reduced airflow for 10 seconds, but it is not within the range of apnea or hypopnea. So let's say that maybe they wake up because there's a 20% drop, in airflow. You can call that RERA. That has not, fallen into the category of hypopnea because hypopnea has to be 30% drop. So that is RERA. So all these three patterns can be experienced in people with obstructive sleep apnea. So what happens?
Sorry, doctor. You mind just leaving up the
Yes, for a
um,
while. Let's look at
okay,
it.
please. Thank you.
Okay.
Yeah, thank
What
you.
does this desaturation mean?
Or reduce.
Desaturation, SpO2.
Right. Yeah. Okay.
SpO2.
Can you bring it up again, please?
So that means this person will have like a sleep test so that you can measure if it's 3% or something.
The person is going to have what?
Do you do like a polysomnography or like how do you or you as in
Yeah, we'll
you have
get
to
there.
know
We'll
the
get there.
baseline, okay? Okay.
Yeah.
Okay.
Are we done?
Yes.
So, what are they going to experience? They are going to have daytime symptoms because at night they are going to be waking up frequently. They cannot sleep. The partners might tell us that they notice that they will try to wake up. Sometimes they are feeling choked, as if they are short of air. They are choked, holding their neck. They are gasping for breath. And for people with adenotonsillar hypertrophy, people that are obese, people that have crowded oropharynx, they'll be snoring badly and they are restless when they are sleeping. So those are just pattern of disturbed sleep. And because they did not get a very good night rest, by the time they are waking up in the morning, they are not refreshed. So they are still sleepy. It's daytime somnolence. They wake up, they are fatigued. They wake up, they can't think. Poor concentration, inability to pay attention. They're having morning headaches. So when they drive, they can have accidents. We are still going to get to the complications. So there's a questionnaire, that you call the Stop Bank Survey. So you are using this to evaluate if you are going to need sleep testing. So somebody comes to the hospital having this kind of presentation, and we we are thinking of, okay, obstructive sleep apnea. So we are going to ask them these questions. S for the snoring. Do you snore? 1 point. T for tiredness. Are you tired? Do you wake up feeling tired? O for observe, stop in breathing. So we ask their partner, do you notice that sometimes your partner kind of stops breathing? P for the blood pressure. Pressure. What is the value of the pressure when we measure it? Is it elevated? B for the BMI. Is it more than 35 kg per meter square? A for the age. Is it more than 50 years? N for the neck circumference. 40. G for the gender, male, because all these things increases the risk of developing all this, kind of, not everything is shared with the risk. Some of them are shared with risk, but all these things are shared with obstructive sleep apnea. So that's the word. All these are associated with obstructive sleep apnea. So anybody that has 3 or more of this feature, you can definitely tell them to do sleep testing. So you want to do a polysomnography, to ascertain your diagnosis. And so what are the complications? Cardiovascular morbidity and mortality. They can have systemic hypertension because the hypoxemia that they experience is going to trigger increased sympathetic activity. So there's systemic hypertension. There's pulmonary hypoxic vasoconstriction, which can cause pulmonary arterial hypertension. The elevated blood pressure too can be a risk factor for coronary arterial disease, can be a risk factor for stroke. The hypoxia is a risk factor for polycythemia due to release of erythropoietin. The hypertension, the pulmonary hypoxic vasoconstriction, all of them, they are risk factor for heart failure. Pulmonary, even congestive heart failure. They can develop arrhythmias from the vascular modification that will have happened, the hypertrophy, the remodeling, even the hypoxia itself can trigger hypoxemia, can trigger arrhythmias rather. Studies have shown that people that don't sleep well, they have increased appetite, they eat too much, they can be obese, and that can increase the risk for diabetes type 2. So you can look at this from the angle of those guys eating too much, or you can look at it from the angle that most people that have obstructive sleep apnea have some obesity, as a risk factor. So because of the obesity, they have a high chance of having insulin resistance and type 2 DA. I put this in part of the question in our endocrine. I don't know if anybody remembers that particular question. Once you make your diagnosis of, I can't remember the way I put the question, but the answer is that choking spell or something. I think that was the answer to
Yeah,
the question.
it's like a boy with brother Willie.
Yes.
And what is the commonest complication? Something like that they are predisposed to.
Exactly. So brother Willie, there's obesity, and the obesity can lead to obstructive sleep apnea. Yeah, that was what I was trying to marry together there. Yeah, thank you. So they can have increases of accidents due to impaired alertness. So impaired alertness, difficulty concentrating, they can have accidents because of the problems with their concentration, from the poor sleep. So the best initial test to do is our polysomnography. And what we are trying to measure is the apnea-hypopnea index. So the doc that was asking me a question about the measurement too, this is where we do the measurement. So when they are sleeping in the hospital, they are going to be in the hospital, and when they are sleeping, we are going to be measuring the period of the apnea and the period of the hypopnea. And we are going to marry them together and divide it by the total hours of the sleep. So that is going to give us, an idea of the diagnosis. So if we get 5 or more of that apnea hypopnea index plus the symptoms, all the snoring, morning headaches, somnolence in the morning, and the likes, with symptoms, and we have 5, you can confidently say that what we are dealing with is obstructive sleep apnea. But if we don't have any symptoms, but we notice that the person has the apnea hypopnea index to be more than 15, we can also say this person has obstructive sleep apnea and we can manage. So we do all those measurements of the apnea and the hypopnea in the hospital. So what is the best initial treatment? The best initial therapy is lifestyle modification. First, with our CPAP. That's what we are going to do first. They can't escape CPAP. We have to tell them to reduce their weight. If applicable, if the person is obese, we have to tell them to stop smoking, if they are smokers. Then we place them on CPAP, because what CPAP is going to do, because CPAP delivers continuous airway pressure, both usually at expiration, but that pressure is still going to be maintained at inspiration, continuous, the same pressure, so that it's going to keep the airway patent, and it will allow for relief of that obstruction. That is what we are doing with our CPAP. If this fails, we can give them oral appliances. We can tell them to wear some braces, which is going to protrude the mouth. It's going to bring out the jaw so that we can widen the diameter of the airway. We can do hypoglossal nerve stimulation. Stimulate the tongue, is going to bring the tongue forward. Or we can do some surgeries, some maxillomandibular advancement surgeries, reposition the lower jaw so that you can relieve that obstruction. And last resort, if everything fails, is to do the tracheostomy. So the next is the obesity hypoventilation syndrome. So here, these guys are having more problem with hypoventilation. That is it. So they are obese. This one is constant K. Obesity is part of what you are looking for in your diagnosis. They must be obese before you can have obesity hypoventilation syndrome. So it's just like obese individuals which are hypoventilating, and you cannot find any other cause of the hypoventilation. You have checked. This person is not having myasthenia gravis. He's not having Guillain-Barré. He's not having ALS. He's not having Guillain-Barré. It is a diagnosis of exclusion, but this person is fat and is hypoventilating, and you have ruled out other causes of the hypoventilation, which present as hypercapnia of more than 45 millimeters of mercury. You can confidently say that this person is dealing with obesity hypoventilation syndrome. So hypersomnolence in the daytime, obesity, that's one of those things we are going to see, and they are going to have some sleep disturbances. So let me just walk us through the pathophysiology problem. I want to tell us, sorry, we need to know that it's divided into 3 levels. So the structural, the central, and the obstructive component. So of course, the obstructive component is very straightforward. They are having obesity. There's an increase in the neck mass. There's a crowdiness within that neck, which increases airway resistance. That's number 1. Number 2 is the structural. They are obese. There's a lot of fatty infiltration of the respiratory muscles, the bones, and this kind of impedes on the ability of the muscles to contract very well during inspiration to allow air to come in. So they have a form of restrictive lung disease. So they cannot take in air very well because of that problem with the fat infiltrating the part of the chest wall. So what they try to do is they try to hyperventilate. They try to increase their respiratory effort. But this cannot help them because the muscles are already weak. Their problem is now going to get worse when they now start sleeping. So that is where the central component now comes in. I want to remind us that during REM sleep, that wakeful respiratory trigger drops. The wakeful respiratory drive at REM sleep drops. So now imagine that somebody's already having problem ventilating due to the fact that there's fat in the chest wall. The person is now sleeping again. There's a further drop, in the wakeful respiratory trigger. It means that hypoventilation is now going to dampen the respiratory drive, such that when they are even awake, they will not be breathing well, because the respiratory drive is blunted due to excessive hypoventilation. Number one, from the structural problem that they experience. Number two, from the central problem.
Can you please say this again, Baba? I didn't get you. Please, sorry.
So, just you understand the mechanism of restrictive lung disease from obesity, right? So that is a structural component causing the hypoventilation. Now, what now happens again is that when these people are sleeping in the night, you know that normal physiology, when everybody is sleeping, the wake there's when it gets to the REM stage, the wakeful respiratory drive reduces. Now, that reduction in that wakeful respiratory drive is also going to cause hypoventilating, because you are not going to be breathing as fast as when you are awake. Now, that means that there's a form of hypoventilation that is now superimposing on a structural cause of hypoventilation. So both of them together, they are going to blunt the respiratory drive, because it's going to be happening in cycle. Do you get? When the person wakes up, the wakeful respiratory drive is going to come back, right? But the person will not be able to breathe air because of the obesity affecting the chest wall. So the cycle continues. When the person sleeps, respiratory drive will suppress it again. So that person is going to be existing in like a state of chronic hypoventilation. I don't know if that makes sense.
So because of the drop in the wakeful sleep during REM sleep, right?
Yes.
Okay, it also drops in them, but when they wake up, that's where I missed it. The drive again is decreased or something.
No.
That's what
you see, when they wake up, yeah, the drive can come back. But do you think they will breathe well? They will not breathe well because of the structural component.
Yes.
So you can see that they are like living their life in a state of hypoventilation.
Okay, while awake and while asleep.
So while awake and while asleep.
That is it. So that is why the clincher you are going to be looking for in the question is diurnal daytime hypercapnia. That is what is going to separate it from obstructive sleep apnea, because obstructive sleep apnea, they only experience their own symptoms at night. By the time they wake up, they are fine, they are doing well. But these guys, they experience their own symptoms both daytime and nighttime. For obstructive sleep apnea, they are going to give you the laboratory values for daytime and nighttime. You notice that nighttime, they are going to be having their hypercapnia. By the time they wake up in the morning, hypercapnia is gone. But these guys, nighttime, there's hypercapnia, daytime, there's hypercapnia. So you don't even need them to give you the two. Most of the time, they will only give you one, which is they can give you the...
Okay, so the normal respiratory drive at night, like in a normal person, in them is decreased at night.
Yes.
Okay.
It's
decreased in everybody. Do you understand?
Well, let's say like normally your respiration is depressed when you are in REM sleep.
Yeah.
Now because they have a pre-existing hypoventilation.
You get it.
Because of the obesity compressing the lungs and all that restrictive effect. That normal effect now drops it further for them.
Yes.
That's what I'm saying.
So what are it's a diagnosis of exclusion.
Sorry to take you back. You were trying to say something before you were interrupted. So you were trying to explain the difference between when we say on question between the obesity hyperventilation and that of OSA. Could you just comment? Sorry.
Yeah, so for OSA, for obstructive sleep apnea, the hyper, you know that the consequence of hypoventilation is hypercapnia. That's what you are looking out for. Because OSA, they are going to be all right when they wake up. Hypercapnia is not there, but you find the hypercapnia at night. But for obesity hypoventilation syndrome, they are hypoventilating at all times. So it means both day and night, they are going to have hypercapnia. So once you see a question showing you daytime hypercapnia, you are seeing the PCO2 more than 45 in the daytime, you know that that is classic obesity hypoventilation syndrome. Now, there's another thing I share with obesity hypoventilation syndrome. In 90% of the cases, it's going to be associated with OSA. So, in 90% of patients with OHS, they are going to have OSA with it. 10% is only going to have sleep-related hypoventilation, which is the one we have discussed. So 10% is just OHS with their sleep-related hypoventilation, that is all. But 90% is going to have both feature of OHS and OSA together. But you know that because of the presence of the OHS, the reading is going to be showing the diurnal hyperventilation. So don't say that it should be the have OSA, it should be normal in the month. No. Because of the fact that that OHS is present, they are going to be having all the features of OSA, which is a nighttime hypercapnia, as well as the daytime hypercapnia. So that is that. So because of the fact that 90% can have this OSA, so you are going to manage them as OSA. So you just do your lifetime education. If they are smoking, stop smoking. If they are having weight loss, okay, let me just be showing us so that it will follow. So it's the diagnosis of exclusion. Definitely you have to identify that the person is obese, BMI more than 30. You have to show feature, you can see, of awake alveolar hypoventilation, PCO2 greater than 45. And you have excluded the other causes of hypoventilation causing hypercapnia. That is OSA. That is OHS. So what is the best initial treatment? Weight loss, and of course, the non-invasive positive airway pressure, the PAP. So once you know that you have identified that, okay, this is OHS, but they have some, OSA component with it, you have to place them on CPAP. CPAP is going to take care of it. If CPAP fails, give them BiPAP. The reason why BiPAP might help is that BiPAP is different from continuous because continuous delivers equal pressure both during inspiration and expiration. BiPAP delivers more pressure during inspiration and expiration. And you need that pressure to take in air. You know that the initial problem in hypoventilation people is that they cannot take in air. They are hypoventilating. So your BiPAP is going to increase your, the pressure drive to take in air during inspiration, and it's going to still maintain some level of expiratory positive pressure to take out air so that CO2 will not keep accumulating. So, but individuals with OHS, that the problem is strictly hypoventilation. OHS with strictly hypoventilation, they don't have any obstructive sleep apnea component with it. You just give them BiPAP straight up because their problem is strictly hypoventilation issue. So give them BiPAP so that it will help them with the ventilation to take in air during inspiration and also take out air during expiration. If that fails, you can now do bariatric surgery, weight loss surgery to reduce the weight, because you definitely know that one of the problem in OHS is obesity. So you must treat it, bariatric surgery. Or you now eventually do tracheostomy as a last resort. Let me see. I think there's a question here. Let me just see. I don't know what is there. Okay. So a 47-year-old man a 47-year-old man is evaluated for I don't think, well, let's just try. A 47-year-old man is evaluated for progressively worsening dyspnea and exertion for several months. The man has frequent awakens at night due to choking sensation and feels tired all the time, limiting his physical activity. He does not use tobacco, alcohol, or illicit drug. The blood pressure is 160/600, pulse is 80. BMI is 48. Jugular venous pressure is difficult to assess due to neck fat. The heart sounds are distant with no murmurs or gallops. Bilateral breath sounds are normal with no crackles or wheeze. Trace bilateral pedal edema is present. Chest X-ray reveals poor inspiratory effort, but clear lung fields. Which of the following additional finding is most likely present in this patient? Anybody knows what we?
I think B, because of renal compensation for the respiratory acidosis.
I think B.
Yeah, so that makes sense. That's
B.
so they are having CO2 retention. So you need to, because of the CO2 retention, that is respiratory acidosis. So you need to do a metabolic compensation, which is reabsorbing your bicarbonate. Yeah, and you know that there are two major anions, within the extracellular fluid. So one have to go for one. So if you have too much bicarbonate, that means you have to let go of your chloride. So you're going to have increased chloride, excretion due to the bicarbonate retention. So that's okay. So moving on to disorders of the nose and the throat. So rhinitis is just inflammation of the nose. Ideally, rhinitis should be taken together with sinusitis. They are like the same thing. So, but was separated. So they have symptoms of rhinorrhea, which is drainage of nasal discharge, but anteriorly or posteriorly. So people can actually be draining the nasal mucus posteriorly into the throat, and you see them experiencing this tendency to be clearing throat every now and then. And they are coughing. Yeah, it's because of the posterior nasal drip. They can have nasal congestion with their nose is stuffed. They can be sneezing from time to time, and some of them can experience some itching, nose itching, body itching, particularly people with the allergic component of rhinitis. So most of the forms of rhinitis involve inflammation, except vasomotor. Vasomotor is not mediated by inflammation. So we can classify into allergic rhinitis and non-allergic rhinitis. So allergic rhinitis is mediated by a type 1 hypersensitivity reaction. Type 1 hypersensitivity means that it involves IgE, and then IgE is going to cross-link with the mast cells to cause degranulation of mast cells. And when mast cells degranulate, they release histamine, leukotriene, and the other stuffs. And that's going to drive the inflammatory process. Because this is an atopic condition, you can have some associated disease, such as asthma and allergic dermatitis. So these are part of the questions we are going to be asking in our history. Yeah, this person is complaining to us that from time to time, he experiences recurrent nasal discharge, feeling as if his nose is stuffed, constant clearing of the throat, and he noticed that some part of the nose, itches. You want to ask, do you experience cough, chest tightness, difficulty in breathing from time to time? Do you notice some form of lesions in your body? Particularly maybe the flexor, that is very, very pruritic. You notice that you are trying to rule out allergic dermatitis and asthma. So, depending on the allergy, because this is allergic rhinitis, is in response to some particular allergy. So, it can be intermittent or seasonal, particularly people with the pollen sensitivity or people with hay fever. So, because you tend to notice that these grass, trees that forms this pollen, they kind of come out during spring and summer where there's sun, everything is bright. So that's when they experience their own symptoms. It is seasonal, only at spring or summer. While some people, they are going to have it persistently. Yeah, because the allergic triggers are around them. Either dust mites, mold, dog's hair, the fur of the cat, normal common stuff. Studies have shown that food allergen too can also be contributing to allergic rhinitis, but we don't have much evidence yet. So we'll focus on these two. So how do you make the diagnosis? Clinically, we can make diagnosis based on history, just like we have talked about, the presentation, the recurrent congestion, rhinorrhea, itchiness, the cough. We can rule out asthma, rule out dermatitis. Look at that nose. You are going to see nasal mucosal hypertrophy with congestion of the turbinate. So bulgy nasal mucosa with hypertrophic turbinates. And we can also see nasal polyps. Sometimes in people with recurrent allergic rhinitis, they can develop nasal polyps. So after that, the next thing is to do identification of the allergen. So we do skin prick test. So they have like should I call it a test kit that contains the common allergen, and they kind of introduce it into the skin. Fine. The problem is with the nose, but remember the IgE rather, the mast cells, everything that is triggering this problem, they are circulating within the blood. So definitely they can react when you inoculate the antigen to the skin. So you get that test kit, you put all the common allergen there, and you check for the one that forms the reaction. So anyone that causes the induration, you know that is that is a particular allergen that's causing the problem. You want to tell the person to avoid anything that is linked to that allergen. Then also you measure your total IgE. We can see that the investigation is following what we do in allergic bronchopulmonary aspergillosis. Everything is like similar. You do your skin prick test, you measure your total IgE at the end of the day. Then you do your serum radio allergosorbent test. So last, so this test is just to identify specific antibodies to some allergen. So you know that we remember that in in allergic bronchopulmonary aspergillosis, we're also identifying IgE that are specific to aspergillus, not IgE specific to pollen, not IgE specific to chemicals, but IgE specific to that allergy. You can identify that by doing your RAST, your radio allergosorbent test. So by the time you take your history, you identify your allergen by doing your skin prick, you measure your IgE level, and you can do your RAST. So from your skin prick test, you know whatever you are dealing with. You tell the person, avoid pollen, avoid dust mite. Just tell them what they are going to do. Maybe they have to clean their house, or use masks when they are cleaning houses, or just tell them to avoid playing around during summertime, springtime. Then we want to place them on medication. So usually we use combination of this non-sedating second generation antihistamine like Loratz, like cetirizine and fexofenadine with steroids. So intranasal steroid, both of them intranasal. Fluticasone, beclometazone, and mometazone. So you can use any one of them, you combine them, you are reducing the inflammatory drive. Remember that histamine plays a major role in that inflammation. So it makes sense to give antihistamine and to give steroids. So in people that that this is asthmatic trigger, they have asthma with the stuff, give them leukotriene antagonist to further control the asthma, like montelukast. So if you have done all these things, we have told them, avoid environmental antigen, take your medications, and the symptoms are not still improving, you have to do immunotherapy. So immunotherapy is just injecting a particular concentration of the allergen, increasing it over time, till the person becomes desensitized. So they can get like an injection of pollen, they'll keep injecting, they'll be increasing the dose over months to years until the person no longer responds. So that's immunotherapy. So that's that about allergic rhinitis. Moving on to non-allergic rhinitis. So this just means that it is not due to an allergy or infectious cause. So there are so many things that can cause it, ranging from irritants. So people working with, just like we have irritant contact dermatitis, we have allergic contact dermatitis. We also have irritant rhinitis. People getting exposed to some irritants like chemicals, smoke, especially cigarettes, car exhaust, pollutants from industries, occupational chemicals and products. All those things can irritate the nasal mucosa, leading to rhinitis. Vasomotor. Vasomotor is just due to vasodilation, increasing blood flow to the nasal mucosa. Usually, it occurs in people that get exposed to irritant odors like some strong perfumes, dry hair, or temperature change. Cold hair, cold, dry hair, perfumes can increase the blood flow to the nasal mucosa, leading to vasomotor. Don't forget, it is the only one that is not associated with inflammation. The gustatory. So some people, after tasting some particular food, you will notice this. I think this happens to almost everybody. You taste some food that's very spicy, you start seeing water, running down the nose. So that is due to stimulation of the muscarinic receptors in the nose, which increase the nasal secretions. Or people that take alcohol, they can have gustatory rhinorrhea too, all due to activation of the muscarinic receptors. It can be drug induced. Some particular drug, particularly the antihypertensives, like all those clonidine, metidopa, ACE enzymes, cocaine, NSAIDs, and our PDE5 inhibitors. So just think about all those sildenafil, tadalafil, NSAIDs, antihypertensive, cocaine. All these drugs can trigger rhinitis due to affectation of the neurotransmitter signaling. They can provoke release of acetylcholine that is going to, cause increased secretion of the nasal mucosa, leading to the rhinitis. Then hormonal. So hormonal rhinitis typically occur in people that are pregnant, and it resolves at the end of pregnancy, and it is also very common in people that use OCP. So it has been linked to like estrogen effects, hormonal rhinitis. Then the last is senile rhinitis, which is also known as atrophic rhinitis. Very common in old people, because the nasal gland fails to produce mucus due to destruction. So the area is very dry, can provoke inflammation, which leads to eventual atrophy and sclerosis of the nasal mucosa. So that is very, very common in people that are exposed to radiotherapy too for a long time. They can have senile rhinitis. So don't forget the irritants, chemicals, smoking, car exhaust. Remember the vasomotor, people that take spicy food. Remember the gustatory. The vasomotor is for people that get exposed to temperature like cold air, dry air. Gustatory is people that take spicy food, alcohol. Then the hormonal senile. So the workup is just to exclude allergic. You have to exclude allergic first, then you now start taking your history to the occupation. If the person smokes, the person take alcohol, the person uses OCP, to now narrow down whatever you are dealing with. So the treatment is the same thing like allergic. That's just it. Symptom driven. So you have to tell them to avoid precipitating factors that you have identified. Person is taking some drugs, antihypertensives, NSAIDs, cocaine, sildenafil. Tell them to stop it. Getting exposed to cold air, smoke, avoid that. And you can give them the intranasal corticosteroid with the intranasal antihistamine too. The same thing. Azelastine, fluticasone. You can give them the stuff just like in allergic, and to treat the condition. Sometimes some people can benefit from intranasal anticholinergics like ipratropium too, or decongestants, and then to relieve the symptoms you can do nasal irrigation with maybe saline, and then you can give them intranasal capsaicin. So intranasal capsaicin is very good in people that like all these drug ones now that trigger the nerve to release acetylcholine. So they reduce the nerve sensitivity to the allergy, to the triggers. That's what intranasal capsaicin does. So In the gustatory one, that it's associated with increased stimulation of your muscarinic receptors, you can give them intranasal anticholinergics. It works excellently in there. So nasal polyps. So nasal polyps are just benign hard growth of the nasal mucosa. So that's the most common tumor of the nasal cavity. You just have to remember two major conditions when you see nasal polyps. Remember three major rather. Remember chronic rhinitis, remember allergic rhinitis, and remember cystic fibrosis. Very, very important. Very, very important. And also, okay, I didn't mention that, and also the Samson's triad. So, it can either be allergic rhinitis because of the recurrent, inflammation. It can be chronic rhinitis, of course, which is associated with cystic fibrosis too, because cystic fibrosis can cause chronic rhinitis, and Samstar triad. Those are the things that typically cause these nasal polyps. So one thing about them is that it's usually bilateral. So if you see somebody having unilateral nasal mass or polyps, it's better you biopsy to rule out malignancy or a papilloma than assume that it's just a benign polyp. Because most of the time they are bilateral and they cause bilateral nasal obstruction. Because of the bilateral nasal obstruction, you are going to be having mucus pulling at the end of that obstruction, leading to postnasal discharge. The nose is going to become congested. They are going to be having problems perceiving smell. So hyperosmia, anosmia, postnasal discharge, bilateral nasal obstruction. Please tilt your mind towards nasal polyps, bilateral nasal obstruction. So what are these associations? The Samstar triad. Very important, because people with Samstar triad will have chronic rhinosinusitis in the middle, and that it is stated that chronic rhinosinusitis is associated with nasal polyps. So, it's one of those clincher too in Samstar triad. Once you see chronic rhinosinusitis, nasal polyps, and you say anything related to asthma or aspirin, these guys are tilting your mind towards Samstar's triad. So, how do you investigate? You can just do your coronal sinus CT scan, to look at the lesions. If you are, seeing the patient in the clinic, you can do a nasal endoscopy. And if the nasal masses don't look typical, they are not looking like the polypoidal masses that you expect, or they are unilateral, or they do not respond to treatment, please take a biopsy to rule out malignancy. How do you treat? Steroid is what you give, and you don't use intranasal steroid. They will not work. They will not work. Give oral steroids. Oral systemic steroid is a modality of treatment. Oral steroid is a modality of treatment. In people with asthma or allergic rhinitis, you can give them leukotriene antagonists to add to it so that you can suppress the inflammatory problem by giving your leukotriene antagonists like montelukast, or you give your interleukin-4 inhibitors like your dupilumab, particularly people with the allergic type, allergic rhinitis. Surgical removal is indicated when the obstruction is very severe or it's not, listening to medical treatment. So in those category of people, you definitely need to do a surgical removal if they are not responding to the oral corticosteroids. You should also treat the underlying predisposing factor, like maybe allergy. You have to avoid the triggers and the likes.
Sorry, I have a question.
Okay.
I'm like I always thought that polyp is like a mass, right? And
Yes,
maybe using
it's a mass.
corticosteroids would be for if it's inflammatory. So are these corticosteroids, if it's not inflammatory, just a growth, are they going to shrink it or something?
Yes, it's going to shrink it. That's it.
Ah,
It's going to shrink it. Yes, that's the way it works. It's going to shrink it. So the polyps are actually thriving on the inflammatory stuff. The more the inflammation, the bigger they will be getting. So that's why, most of what causes polyps is due to recurrent inflammation. So once you stop that inflammation, it will go down at the end. So epistaxis. Epistaxis is bleeding from the nose. It can be anterior or posterior depending on the location of the bleeding. So it's very important for us to remember that most of the bleeding, they are anterior, and we need to remember the circulation involved, which is going by the acronym LEGS. L for the labial artery, the superior labial artery, E for the ethmoidal artery, G for the greater palatine artery, S for the sphenopalatine artery. So 90% of the anterior, 90% of the nasal bleeding, occurs in the anterior segment, and most of the time they are self-limited. Sometimes they might not self-limit. You need to act to rescue that person. The remaining 10% occurs in the posterior segment, and the take home here is just that the bleeding occurs from the sphenopalatine artery. Very important. Very, very important. When the bleeding is posterior, it occurs in the sphenopalatine artery. Please, we have to know that the posterior epistaxis is bad compared to the anterior. You need to send a consult to ENT whenever you notice that the bleeding is posterior. So, what are those things that can bring about posterior epistaxis? Just remember nasal irritation, constant nose picking, there's foreign body there's any form of rhinitis, constant inflammation, foreign body, constant inhalation of drugs. It can cause irritation too, like cocaine, intranasal steroids. All those things will bring about irritation, and the vessels there can easily bleed. Or there's facial trauma to the nose, or the person is having some malformations like maybe tumors, nasopharyngeal carcinoma, hemangioma, vascular malformation of any type. They can easily bleed and lead to epistaxis. Or the person has some systemic conditions. Hypertension, number one. Hypertension can cause epistaxis. The vessels can easily rupture because of the high blood pressure. Or the person is on some particular drugs like anticoagulants, antiplatelet. They can easily bleed too. People with bleeding disorders like von Willebrand disease. So these are all these causes are things we can easily think of, things we can easily wrap our head around. So how do we treat? So the first thing is to, assess and check for the airway, breathing, and cardiovascular status. So you want to check if the person has a patent airway, if the person is breathing accordingly. So if the person is not breathing, you want to give oxygen. If the person is not hemodynamically stable, you want to ensure fluid resuscitation immediately by setting your large bore IV line, particularly when it's very severe. But if it's not, and when you are setting your white blood cannula, you want to collect blood samples for your coagulation studies, just like the way we did in hemoptysis. You want to group and cross match, you want to check your coagulation studies. But if it's not very bad, the first thing you do is just to sit up the patient. Then you tilt the head forward and not backward. Because if you tilt the head backward, they are going to aspirate to the airway. So put the head down so that you can facilitate the drainage and prevent aspiration. Then after you do that, you want to apply pressure. You want to apply cold compress. And at the same time, you also want to administer topical drugs like oxymetazoline for vasoconstriction or local anesthetics like lidocaine. So you give your vasoconstrictor to reduce blood flow to that area, and you pinch bilaterally. You pinch the nostrils bilaterally for 10 to 15 minutes. So if you have pinched bilaterally for 10 to 15 minutes, you have given your topical vasoconstrictor and the bleeding did not still stop, you need to look into that nose. What is happening? So do otoscopy or rhinoscopy. You look into the nose with an otoscope, or you use a speculum and look at the source of the bleeding. So if it's anterior, you have to continue. by doing catheterization. If it's posterior, you have to use a balloon tamponade. You use a balloon catheter tamponade, and you send the consult to ENT. So after you have done this treatment and it does not stop, and you have done your rhinoscopy, you have seen that it's anterior, then you can continue by doing cauterization. So cauterization is just a procedure in which you use thermal energy chemical to secure hemostasis within a bleeding. So you just obliterate that vessel with this, your heat or your chemical. So the chemical they use is silver nitrate, or you just use electric bond, electric cauterization. I'm sure like everybody knows diathermy. So it works like the principle of diathermy. If the cauterization did not work, then we need to do nasal packing. So you can pack with tampons or balloon catheters or ribbon gauze. Just pack tampons or gauze or balloon catheter. You pack, if the stuff did not still resolve with your packing, you do a bilateral packing, both nose, not one, both nose. So if
How would
bilateral
they
packing,
breathe? How would the patient breathe if both nostrils are packed?
you are not putting it like that for a long time now. You are just trying to arrest the bleeding. And the stuff you are putting there is not going to occlude the entire space in the nose. So there's still going to be some space.
The mouth is open too.
Exactly. And the mouth too is opened. Thank you. So you do your bilateral nasal packing, and if this does not work, you know that your bleeding is going to likely be posterior. So you have to send consult to ENT to come and rescue them. So for posterior, you can try to do your balloon catheter, tamponading. Then the patient will have to be hospitalized and is sent consult to ENT. So complications can happen, particularly when you do a long period of nasal packing. Most of the time, you don't want to do your nasal packing for more than 72 hours. If you do it for more than 72 hours, there's a very high risk of the person running into complications. Complications like necrosis of the nasal mucosa, or most commonly, the toxic shock syndrome, which is caused by Staph aureus and then group A Pseudococcus pyogenes, in which you just notice that the person suddenly becomes feverish, hypotensive, and develops some skin rash, desquamation, and multi-organ failure. So once you see that, fever, hypotension, desquamation, rash that is desquamating, with maybe kidney failure, renal failure, you are likely dealing with toxic shock syndrome. So moving on to adenotonsillar hypertrophy. So adenotonsillar hypertrophy is just enlargement of the adenoids and the tonsils in the posterior aspect of the nasal cavity. So the adenoids, they grow at the posterior aspect of the nasopharynx. They are also known as the nasopharyngeal tonsils, and they reach their final size by the age of 6 to 7 years. So both the adenoids and the palantar tonsils are located at the back of the soft palate, and they contain the white blood cells. The B and the T are lymphocytes that play a role in immunity. So people with adenotonsillar infection, they are noticed to have recurrent infection, and hypertrophy of the lymphoid structure. So they have recurrent infection because, there's increased surface area. There's increased surface area of those tonsils by the time they enlarge. So increasing, potential size for bacterial colonization and viral proliferation. And at the same time, the integrity of those cells is lost. So they are not able to actively fight those infections very, very well. So even the obstruction that's going to happen from the hypertrophy, the mucostasis and everything is going to also prevent and create a very good opportunity for the bacteria to proliferate and thrive. So they are known to have recurrent infection. So the more recurrent the infection is getting, the higher the chance of you doing an adenotonsillectomy to remove those structures. So, a child with adenoidal hypertrophy, you are going to get history of recurrent mouth breathing because the adenoids are enlarged, they are occluding the nasopharynx. There's no way hair can get behind the behind the nose into the airway. So they will be breathing through their mouth. Number one. Then number two, they are going to be having hyponasal voice, meaning that because of the fact that nasopharynx is blocked, there's no way hair can move from the nose, downwards into the voice box. So that nasal quality is lost. So they are going to be talking as if their nose is stopped. Like, just close your nose and try to talk. That kind of voice. That's what is going to happen. Then they are going to have adenoid fasciae. So which is the best way to remember this is that you notice that their face is going to be very long, their mouth is going to be opened, and because of the fact that they are not using their nose, the nostrils is going to be tiny. So they are going to have a short lip, thin nostrils, wide open mouth. That is adenoid fasciae. So, and because of the obstruction of nasal drainage from the adenoid hypertrophy, you are going to be seeing recurrent rhinorrhea and post-nasal drip, behind the nose. So the same thing also happens for tonsillar hypertrophy, where they are very, very similar. Both of them will have history of recurrent infection. Tonsillar hypertrophy too can have problem with feeding and airway because the soft palate is just like the roof of the oral cavity. So when it's and that is where you have the tonsillar organ. So if it's enlarged, it means that it's very, very difficult for the individual to feed, and from there it can also extend into the airway, causing airway airway obstruction. So what is common to both of them is that they can have sleep disorders like obstructive sleep apnea, because of the adenotonsillar hypertrophy. So they'll be having features of sleep apnea like excessive daytime somnolence, failure to thrive because they are not getting good sleep, enuresis because of the stress, and poor school performance. That's the influence on their cognition and changes in behavior. They might get so aggressive, start throwing tantrums and the likes because they are not getting good sleep. They are stressed. So once you see a child that is having this kind of thing, daytime somnolence, enuresis, poor school performance, you have to rule out adenoid hypertrophy. Or they can tell you, you make your diagnosis of adenoid hypertrophy, and they can tell you which of the following symptoms is going to be present in that child. So that child is definitely going to perform poorly at school. The child might experience enuresis or behavioral disturbance. So so adenoid hypertrophy, you want to rule out other causes of snoring, like maybe anterior nasal obstruction, maybe from a displaced septum or something. So just rule out other causes. But the best diagnostic test to do to make diagnosis of adenoid hypertrophy is to do a nasopharyngoscopy. So you put a scope to the back of your pharynx, to look at the adenoid tissue, if it's big or not. You can also try to do a lateral neck X-ray. You are going to get a visualization, but nasopharyngoscopy is the best. So you can also examine for the tonsillar hypertrophy by the time you tell the person to open the mouth. You can grade it, but I don't think the grading is important. Yeah, because kind of grade, I think like grade 1 to 5 or something. So, but both of them, they go hand in hand together. And if you notice that the individual is having features of obstructive sleep apnea, like daytime somnolence, poor school performance, behavioral problems, you have to do a polysomnography. You have to do a polysomnography to to diagnose that obstructive sleep apnea. I already know the criteria. The apnea hypopnea index more than 15 if there's no symptom. Apnea hypopnea index of 5 if there's symptom. So how do you treat? First, if there's any ongoing infection, you have to treat that infection because it's affected with recurrent infection. So you have to give supportive treatment like pain control, fluid intake, and if you think maybe the infection that is there is like related to acute pharyngitis from streptococcal infection, after you have done your CENTOR criteria, you can give your appropriate antibiotics to treat that. So we already know the component of the CENTOR criteria, it's here. And you have to do tonsillectomy when there's a history of recurrent infection. And what do we mean? If this individual have more than 7 episodes of infection in the previous year, or the person had 5 in the preceding 2 years, or the person had 4 in the preceding 3 years, so you have to do tonsillectomy. Yeah. So most of the time they might not tell you this value. They can just tell you there are multiple recurrent infections. So definitely you know that you have to do a tonsillectomy for that individual. If that person is having features of obstructive sleep apnea, which you have diagnosed with your polysomnography, you have to remove both of them, your adenoid and your tonsil. You perform an adenotonsillectomy. So that's the reason why you are doing your polysomnography. You have to do adenotonsillectomy. Moving on to inflammation of the larynx. So laryngeal inflammation can come from different conditions. Either this person is coughing too much, this person is talking too much. So people that talk too much, shout, sing, they can have strain on the larynx with inflammation. People that cough excessively too, either maybe due to infection or due to drug use like ACE, they can have laryngitis. People that have reflux, particularly laryngopharyngeal reflux, they can have laryngitis because stomach content is getting into the larynx, can trigger inflammation. Or people that get exposed to irritants for a long time, smokers, they can also develop laryngitis. So, they are going to experience hoarseness of voice. Sometimes they can even lose that voice totally. Depending on the cause, they can have, cough. Particularly people with GERD, they can have cough. They can have sore throats, enlarged lymph node if it's infection. So you can classify laryngitis into 2 categories based on the symptom of hoarseness. If the hoarseness is more than 3 weeks, that is acute. If it's more than 3 weeks, that is chronic. If it's less than 3 weeks, that is acute. So hoarseness of more than 3 weeks chronic, less than 3 weeks acute. You need to, perform physical examination of the head and neck to rule out malignancy, because malignancy too can be a cause. So you have to, check for the head and neck to see there's no washed lymphadenopathy, and you can perform a nasopharyngoscopy to look at the vocal cords, look for any lesions. Are you seeing any polyps or nodules? People with GERD and eventual laryngopharyngeal reflux can have polyps and nodules being formed within those vocal cords. You also want to look for cardinal features of inflammation like edema, redness, to rule out infection of this larynx. You want to look at the motion of the vocal cords. Are they moving? If they are not actually moving, that's impending airway compromise. So you want to intervene quickly, either by doing intubation or just securing the airway. Supportive management is often needed with vocal hygiene. You are not telling them to keep quiet, but they undergo this voice training. If it's due to excessive cough, you want to give them expectorant to treat the cough. If it's from drugs, you want to suppress the drug like ACE inhibitor, change it to ARBs. You have to tell them to avoid precipitating or irritating factor like smoking. The people that smoke, people that have GERD, you can treat their GERD by giving them the PPIs. So just treat the underlying cause, and they are definitely going to be fine. So if it's infection, treat the infection accordingly. So laryngopharyngeal reflux is just reflux of gastric content into the laryngeal tissue, causing irritation. So this is one of the causes of laryngitis. it occurs in condition where the integrity of the lower and the upper osseous sphincter is compromised, particularly people with obesity. Obesity increases intrathoracic pressure, and it easily allows for escape of these gastric secretions into the larynx. So they are going to present with cough. They are going to present with sore throat. They are going to have problems with the voice production, dysphonia. There's going to be alteration of the quality, the pitch, the volume of the sound that is being produced. And definitely they can have globus. Globus is just like this foreign body sensation in the throat. It's because of the gastric content that is refluxing. So they will feel as if they are choked or they have something in their throat. So you have to, manage that and have high index of suspicion for GERD or laryngopharyngeal reflux rather. So they can have dysphagia too, inflammation with like stricture. So that can also cause dysphagia, and they are clearing their throats every time, particularly when they wake up in the morning. So because the reflux would have happened overnight when they are sleeping, when they are lying recumbent. So when they wake up, they are clearing their throats, they are coughing, laryngopharyngeal reflux. So you want to get your diagnosis from your signs and symptoms, the way they present, and you want to ensure dietary changes. So tell them to stop taking some particular diet if they take it, like caffeine, chocolate, peppermint, alcohol, acidic food. All these things, acidic food is going to increase the acidic content of the stomach, so they can easily reflux. Caffeine, chocolate, peppermint, alcohol, all these things, they lower the tone of the sphincter, so you can easily have reflux easily with all these things. Smoking also increases gastric acid production, and it also lowers the tone of the sphincter, so they can reflux. You tell them to stop smoking. You tell them if they want to sleep, they should eat more than 2 to 3 hours before going to bed. Yeah, so that the food will have digested. Because if they eat within 2 to 3 hours and they go and sleep, they can easily reflux and they can have symptoms. If they are going to go for exercise, they should eat for more than 2 hours before they go and exercise. So they should not exercise within 2 hours of eating, so that you will have given the food enough time to digest, because exercise is going to increase intra-abdominal pressure and they can easily reflux. So you want to also suppress the gastric acids by giving them PPIs or H2 antagonists that can help them in a way. So moving on to the laryngeal lesions, we have the vocal cord polyps and the vocal cord nodule. So vocal cord polyps is the most common benign laryngeal lesion. So they appear as a gelatinous growth, and they are caused by vocal cord overuse, just like cause of laryngitis too. People that sing, talk, teachers like me now, then maybe like Dr. Babani. Dr. Babani will be the best example. So he has to minimize, or we have to undergo some form of training so that we don't develop vocal cord polyps. So smokers too, they can have irritation of the vocal cord, and it can lead to formation of polyps at the end of the day. People with GERD. So this is just like what we have in people with laryngitis too. Overuse of the vocal cord, smokers, GERD, all of these things can precipitate formation of the polyps, and you see the gelatinous growth within the vocal cord. So they typically present hoarseness. It can get so bad that the motion of the vocal cord is impeded, and it can lead to dyspnea. So how do you investigate? You want to do a laryngoscopy to look into the vocal cords. You want to look into the larynx to see the mass. Most of the time you see it within the posterior two-thirds and the anterior two-thirds of the vocal cord, because that is the area of the highest amplitude. So that's where the trauma happens most of the time. You can do a stroboscopy, in which you are trying to evaluate the frequency of voice production in people with this condition. You expect that if there's a polyp, it will affect the vibration of the vocal cord and the frequency is going to drop. So you want to treat people that are singing, people that teach voice therapy, like a coordinated way of talking so that you can limit that insult, or you can do microsurgery to remove the polyp, if there's serious affectation of the voice. The same thing as Nodu. Nodu and polio are like the same thing, the same cause, the same treatment. It's just that Nodu just look like a callus or lump, the same cause, GERD, smoking, overuse. Both of them present with hoarseness too. You do your laryngoscopy, you do your stethoscopy, voice therapy, microsurgery, treat GERD if there's GERD, smoking cessation, and the like. The same treatment. Then to the last, recurrent respiratory papillomatosis. So this is just like a benign tumor of the squamous epithelium of the upper airway. So you see them as raspberry-like or warty growths, in the upper airway. You find them most of the time in the vocal cords. So sometimes in 3 to 5% of the cases, they can undergo malignant transformation into squamous cell carcinoma. So we have two types depending on the age of onset. So the adult one and the juvenile. So juvenile usually occur, less than 20, but it peaks at 5 years. Adult one is one that are developed after 20 years. So people with the juvenile one, they can have repeat procedures to removing, because the condition is recurrent. You keep going, remove. So they can get like 20 procedures during their lifetime. So it's that bad. And remission usually may occur over several years. So people with the juvenile form typically get it during peripartum transmission from their mother. So vertical transmission during during delivery. That's where they get it. The adult one is transmitted through oral sex. So there's high risk, for the juvenile form to occur in a child that is born to a teenage mother, particularly as a firstborn and when it's through vaginal delivery. Because when it's the firstborn, that's the first contact. It's fresh there. And the mother is teenage. Teenage may have a very high tendency of experiencing prolonged delivery. So there's more time to get exposed to the infection. And it's not vaginal, it's not CS. So they can easily get infection. The infection, which is the human papilloma virus, serotype 6 or 11. Serotype 6 or 11, not 16 or 18, but serotype 6 or 11, that causes what? So it's very, very common in people with low socioeconomic status. And if you see a child that is more than 5 years that developed it, you might want to rule out sexual abuse, because the juvenile form peaks within 5 years. So if it's more than 5 and the person is just developing it, there's a high tendency that that child is being molested sexually. So for the adult form, people that have multiple sexual partners and they practice oral sex, they have a very high tendency of developing the condition. So what do you do? Okay, for the symptoms here, so most common presentation is hoarseness of voice. So because this is a tumor affecting the vocal cords, the larynx, sometimes the trachea. So there's hoarseness, and because of the fact that it affects the upper airway, there's going to be wheezing and stridor. So inspiratory stridor, very, very, very high yield for upper airway obstruction. Inspiratory stridor, wheezing, hoarseness, and depending on the size, it can lead to dyspnea and then choking. So they can have this foreign body sensation, globus, as well as coughing. So you do your laryngoscopy to look at it, or your bronchoscopy. Most of the time you use the laryngoscopy. You're going to see the wat-like raspberry swelling in the vocal cords. There's no cure. So you can try to do microdebridement. So that's why you see that the child, for the juvenile one, they can get as high as 20 procedures during their lifetime. So you try to debride, you remove, it comes again, you remove, or you use like CO2 laser to kill or, debulk that that tumor. Sometimes because, this is a viral cause, so you can give them cidofovir or acyclovir or ribavirin. Sometimes if there's intolerance to any of this, you can use interferon therapy as second line. So if there's significant airway obstruction, the person's already having mad stridor at rest, very difficult to breathe, you can do a tracheostomy. You prevent this by giving quadrivalent HPV vaccine, particularly against the serotype 6 and 11. So we come to the end of respiratory medicine. Do we have any questions?
Dr. Baba, I have some questions, please. With regards to the oh my goodness, he says something about when you're talking about the adenoid hypertrophy or tonsillar hypertrophy. He says something about grading.
No. I said tonsillar hypertrophy. I said we should not worry ourselves about the grading. I said we should not worry ourselves about the grading. That's what I said.
Okay. And he said also adenotonsillar hypertrophy is characterized by recurrent infections. I mean,
yeah.
I'd like to know more about some explanation you made.
Yeah.
I didn't quite get it.
I was talking about the increased surface area to allow bacteria to proliferate. I said the immune cells there, they are not active. And I said the obstruction too is going to allow mucus to accumulate so that they can thrive.
Okay.
Yeah.
Okay, I think let me
Thank you.
The hypopnea you explained. Can you explain that for me again, please?
Which one?
I get that. Yeah, when you were discussing on the obstructive sleep apnea, the hypopnea.
Yeah, I said hypopnea is when you have a 30% drop in inspiratory airflow.
Inspiration.
Yeah, airflow reduces by 30%, and it makes the person wakes up, or you notice desaturation by 3% from baseline. So that's hypopnea.
Drop in inspiration more than 30 minutes, 30%. Okay. I think I have now. I don't know if anybody has another questions.
Thank you. Please, this may be basic, but what's the difference between tonsils and adenoids, like as maybe anatomically, so I can appreciate the pathology?
Yeah, so if you look at the Wadea ring, you see the alignment of all those tonsils there. We have the tonsils at the nasopharynx. That's the adenoid. We have some at the palate. That's the palatine tonsil. We have some at the lingual. So the one at the nasopharynx, this is the adenoid. So we have one here, the tubal. We have one at the palate, palatine tonsil. We have one at the tongue, lingual. So the one we are discussing today is this and this. So they can get enlarged and they can obstruct the airway here.
That's the pharyngeal and the palatine tonsil.
Yeah, the pharyngeal and the palatine tonsil.
Then which ones are the adenoids?
The adenotonsils.
Yeah, I said the adenoids are the pharyngeal tonsils. Adenoids also called pharyngeal tonsils.
Okay.
The pharyngeal and the palatine.
So for adults, that they kind of regress automatically, or what? Like this adenoids?
Yeah, it will reduce in size in adults.
Okay.
Yeah.
Okay, so these are like they are lymphoid tissues. So.
Yeah, they are lymphoid tissues. They have B and T cells. They help to fight infection.
Okay.
That is what they do. Any other question?
Yes. Oh my goodness. Okay. The anthrax. Your question was on anthrax. Hello?
Yeah, I'm listening.
Yeah. can you just briefly summarize that, because I think I missed my next
Antonia, I cannot summarize. I'm sorry. You have to watch the video. I'm tired.
Oh.
I need to go and get a rest. I can't summarize that. That is like summarize. No. You watch the video.
No, I know you have the inhalation and I know you have the injection. The injection will give you the GI symptoms, right? The inhalation will give you more of the pneumonia.
Yeah.
Pneumonia and possible hemorrhage.
Not pneumonia. Mediastinal.
Mediastinal hemorrhage. Linked to mediastinitis.